And CT or MRI of the patient. Okay, so that's all about the hydronephrosis. Like all the causes are very important, right? The stones, BPH, congenital obstructions, cervical cancer, any injury, fibrosis because of any surgery or because of any radiotherapy, vesicular reflexes. All of that can cause a dilation in the tracts of the kidney, for example, the pelvis and the calyces. Okay, so step one can give you a gross picture of the kidney, and they will ask you whether it is a case of hydronephrosis or not. You will look for all the things in the kidney, and if you saw dilations of the calyces and the pelvis, then of course you will be having a hydronephrosis. They can further ask you about this pressure atrophy thing. Okay, and please note that the size of kidney will be decreased because of this increase in the pressure. What's going to happen to my renal plasma flow because of this obstruction?
No effect.
No effect on the no effect on the renal plasma flow, but you have a decrease in the filtration fraction, right? And the GFR also, because you're having an increase in the hydrostatic pressure in the Bowman's space, right?
Yes. Yes.
Yeah.
So any doubt on the hydronephrosis?
No, thank you.
Then you have the urinary incontinence. Okay. So one thing is a urinary retention in which you cannot picture it. And second is a urinary incontinence, in which you cannot hold your urine. Okay, so it could be of three types: the stress incontinence, urgency incontinence, and the overflow incontinence. So look at the name of all these diseases. In the stress incontinence, you will have incontinence whenever you got a stress, whenever you have an increase in the pressure in the abdomen. Okay, and it happens because of the outlet incompetency. Okay, because the sphincters become very weak, they cannot hold the urine into the urinary bladder, and as a result you will have a leakage of the urine whenever the pressure in your abdomen increases. In the urgency incontinence, you will be having a urgency on the micturition. You cannot hold the urine, you will get a sudden urge to micturate. Okay, and then you micturate, okay, without even reaching the washroom, for example, right? So it happens because of a overactivity of the detrusor muscles. So patient got a sudden urge for the micturition that they cannot hold their urine. In the overflow incontinence, this incontinence is happening because of overfilling of the urinary bladder, and as a result, because of this overflowing of the urinary bladder, you cannot micturate properly. You will have a incomplete voiding of the this urine from the bladder, and as a result, you will have an overflow, and you will have a continuous dribbling of the urine, okay, throughout the day. It is not related to any pressure, any stress. It is not related to any urgency. You have a continuous this dribbling of the urine throughout the day. Okay, so let's discuss all of them one by one. In the stress incontinence, you will be having the outlet incompetency. Okay, it could be either due to a urethral hypermobility or intrinsic sphincter deficiency. Whenever you have a hypotonia of the sphincter, okay, that could be due to a damage in the pudendal nerve, for example. Okay, and as a result, you will have a leakage of the urine with increase in the abdominal pressure, for example, while sneezing, while lifting any weight, during the valsalva. Okay, so whatever the thing increases the pressure on the bladder, you will have a stress incontinence. Okay, so the patient will have a leakage from the urethra upon coughing or upon valsalva maneuver. So it would be an episodic incontinence the patient will get whenever the increase is the abdominal pressure, for example, while sneezing or while coughing or while lifting any weight, right? Associations could be the obesity. Okay, it could be due to a vaginal delivery. Okay, with successive vaginal delivery, you can have an incompetency. Okay, prostate surgery can also do that. Hysterectomy can do that. Okay, in the pregnancy also, in the this third term of the pregnancy, uh, this mother will have a very increased size of the uterus that can put a overload on the urinary bladder, and as a result, the urinary bladder cannot hold of the urine, and if a further increase in abdominal pressure happens, the patient can also have the incontinence. So in the third trimester, due to an increase in this in the size of the uterus, the patient can have a stress incontinence also, because this patient already has a very high pressure on the ureter, and if this pressure further increase because of any increase in the abdominal pressure while coughing or while sneezing, then patient can have a incontinence. Okay, so obesity, vaginal delivery, prostate surgery, hysterectomy, and the pregnancy, especially third term. Okay, all of these things can cause the stress incontinence. Treatment include tightening the pelvic floor muscles, and that could be done by the Kegel exercises. Okay, there is a posture for the Kegel exercise. Okay, and it will help tightening the muscles of the pelvic floor, that are the levator ani muscles. Okay, if the patient is obese, then she need to do the weight loss also. Okay, so all these things for the treatment of the stress incontinence. The second you have is the urgency incontinence, and that happens because of overactivity, over contraction of the detrusor muscles, and as a result, the patient will get a sudden urge to void immediately. She will have this incontinence without even reaching the washroom or something, right? So it can happen because of the urinary tract infection. In the UTI, patient will got an increase in the frequency of the urine. They will have the urgency of the urine, so they will got a sudden urge uh, of this micturition. Okay, with with increase in the frequency, with with many number of times in a day. Okay, so these are basic symptoms of the UTI: frequency and urgency. And dysuria, of course, is present. This can also happen because of the multiple sclerosis. If you guys go back to the neurology, we have discussed that your brain inhibit the micturition. Okay, if you have any kind of upper motor neuron palsy, for example, in case of multiple sclerosis, you can have a loss of micturition reflex, and as a result, you will have a urgency incontinence. In a very early disease, you will have an urgency incontinence. In the late disease, you will have an overflow incontinence in multiple sclerosis. Any frontal lobe damage can cause the urgency incontinence, and that's exactly what happens in the multiple sclerosis. Treatment, again, giving the patient Kegel exercises. The patient need to do the Kegel exercises, stretching the levator ani muscles or the pelvic floor muscles. Second thing, because of this overactivity of the trapezius muscles, you need to inhibit the muscarinic receptors. So anti-muscarinic agents could be given like the oxybutynin, or the beta receptor agonist can also be given. And does anyone remember what beta receptors are found in the urinary bladder?
Beta 3.
Beta 3, and they would be stimulated by the mirabegron. Okay, so these are the agents you will give the patient for the urgency incontinence. Then you have is the overflow incontinence, and that happens because of a blockage in the outflow of the urine. For example, in case of BPH. Okay, and now as a result, because of this blockage, the patient cannot completely, empty the urinary bladder while micturating, and as a result, the patient will have a overflow of the urine in the urinary bladder, and because of this overflow, because of this incomplete emptying, patient will have a continuous dribbling of the urine throughout the day. It will be an involuntary and continuous leakage of the urine. Okay, because of this overflowing, patient also get a nighttime micturation oftenly. Okay, they always micturate in the night without even drinking of water because of this overflowing of the urinary bladder, right? Now, associations, one thing is the diabetes. In the diabetes, you can have a damage of the neurons, right?
Yeah.
Now, if you get a damage in the sensory neurons, okay, the sensory supply to urinary bladder, in that case, you cannot sense whether you are having an empty this bladder or not, right?
Right.
So now, because of the sensory damage, patient cannot sense whether he got this empty this bladder. So they will have the incomplete micturation, incomplete voiding of this bladder, and as a result, they will have a overflow incontinence in the diabetes. It is because of a neuropathy. So always note, whenever you encounter a patient having an overflow incontinence because of diabetes, they must have a history of the neuropathy. It could be a paresthesias, it could be a paralysis, it could be a hemato, it could be anything, claw feet, it could be anything, right? So they must have a history of any neuropathy. It could be there's what do you call the diabetic, I'm forgetting the name. What's GIT? In the GIT, you have diabetic gastroparesis, right?
Yeah.
Yeah. So they will have this kind of a neuropathy history first. Then only you will suspect the patient having a very, late stage diabetes. It must be a case of late stage diabetes. Patient can also have a damage in the kidney. Nephropathy could be there. Okay, so then only will suspect a patient having an overflow incontinence because of diabetes. If you encounter a patient who is having a diabetes history of 3 or 4 years, then you cannot suspect the overflow incontinence in this patient because of diabetes. It must be because of some other reasons. Okay.
Yes.
Second thing is the BPH. Of course, BPH can cause the obstruction in the outflow of the urine, and that can cause an overflow incontinence again. In the multiple sclerosis, in the late stage of the multiple sclerosis, patient can also have a overflow incontinence. So please note, for the diabetes, the patient age will be less than 50. In the BPH, because BPH is mostly present in the patient having an age more than 50 years, you will suspect the overflow incontinence because of BPH only when the patient is having an age of more than 50 years. Less than 50 years, think about the diabetes if they have a history of diabetes for more than 5 years, of course. Okay. Now, treatment, again, giving the patient relaxing agents like the alpha blockers. And does anyone remember the name?
Prazosin, terazosin.
The prazosin, trazodone, tamsulosin, alfilosin. Okay. These drugs would be given. So that's about the all the urinary incontinences. Any doubt, please ask.
I have one question.
Yes.
You said that in MS, earlier we get urgent incontinence and then later on we can get overflow incontinence. Could you explain
Yes.
that?
I mean, what's explain? Sorry, I didn't understand.
Like, how does urge incontinence occur earlier and then later on we get overflow incontinence?
And the urgent incontinence happen because of a damage in the pathways of these tracts, right? See, this micturition reflex consists of three pathways. One you have this CNS, the brain mainly. Then you have a spinal cord, and then you have the peripheral these neurons. Okay.
Yeah.
The function of your brain is to inhibit the micturition. Function of your spinal cord is to cause the micturition, and same thing goes for your nerves, the peripheral nerves. Okay. So
Okay.
once you have a damage in the brain, in the upper motor neurons of the CNS brain, you will have a urgency incontinence. When the upper motor neurons of your this spinal cord got damaged, you will have this overflow incontinence.
Okay.
I will
Okay.
get this more detail. Don't worry. I think in the next session we will discuss in more detail about that. Okay. I will make a proper slide how to got this reflex of the micturition.
Okay. Thank you.
That would be better for you. Okay. So I will make a perfect slide for that. Don't worry about it. It is a very complex thing actually. You will have a brain involvement, then a spinal cord involvement, and then the peripheral nerve involvement. And then you will have this micturition completed.
Yeah. Okay.
Now, other thing that you must know, because you know it in case of my overflow incontinence, you're gonna have a blockage in the pathway of the urine, right?
Yes.
So in this overflow incontinence, you can also get the hydronephrosis.
Yes.
Okay, so one other symptom that you will find in the overflow incontinence is having a patient with hydronephrosis. They will have a pressure atrophy and you know all these things. Any more doubt on the urinary incontinence?
No, thank you.
That's about the urinary incontinence. Now let's discuss the UTIs. You have two types of UTI. One is the cystitis, and second is the pyelonephritis. You call it a cystitis when the infection reach only up to the urinary bladder. When the infection involves only the urinary bladder, you call it a cystitis. You call it a pyelonephritis when the infection reaches to the kidney. So the infection of kidney known as pyelonephritis, and the infection of bladder is known as the cystitis. In the pyelonephritis, you can have a cast because it is involving the kidney. In the cystitis, you cannot have the cast because it is involving only the urinary bladder. Okay, so let's discuss all the symptoms you will get. Now, because of the inflammation in the urinary bladder, you will have a suprapubic pain. Okay, first symptom. You will have a dysuria. You will have a pain with the micturition, this micturition. Urinary frequency you will get a frequent episodes of micturition throughout the day, 10 or 12 times maybe. Urgency incontinence will be there. You will get a sudden urge to void. Okay, and before even reaching to the washroom, you will get the micturition. You will get the incontinence before that. So suprapubic pain, pain with the micturition, frequency of the micturition, and urgency of the micturition. That you will see in the symptoms of the patient with cystitis. Please note the systemic signs and symptoms of the inflammation, that is a fever, chills, fatigue. All of these things are absent in the acute cystitis, while the fever, chills, flank pain are present in the pyelonephritis. So if you encounter a patient having this frequency, urgency, dysuria along with fever, think about the pyelonephritis. If you're having a patient with just frequency, urgency, dysuria, you will think only about the cystitis. Risk factors include the female sex because they have a shorter urethra. Okay, any sexual intercourse can do that. Indwelling catheters can do that, and you know, I told you already about all these nosocomial infections which can cause a UTI.
Yes.
Remember, some and who was the most common one? Nosocomially.
Klebsiella.
Not a Klebsiella. Most common cause of nosocomial UTI, no, not the Proteus. Try harder. Most common cause of nosocomial UTI, a multi-drug resistant organism. Not a Pseudomonas. Pseudomonas is an important cause, but not the most common one.
Staph epidermidis.
You are close. Think much. Just a little bit. E. coli is overall the most common cause, but not the most common nosocomial cause. It's one of the Staphylococcus. Oh no, one of the streptococcus actually.
Pyogenes.
Now, I mean, not like the streptococcus, but somewhat closer to them. Okay.
Enterococcus.
Enterococcus, exactly. Enterococcus is the most common cause of nosocomial UTI. Okay, because it is a highly multidrug resistant organism. Okay. Then you can have this Klebsiella, E. coli, and all other organisms. Okay, the Proteus, Pseudomonas. Okay, they always come later than that. Staphylococcus aureus can also do that. In the nosocomially, Candida can also do that nosocomially. Okay, so remember all these causes. Diabetes can also do that because in diabetes you will be having a glucosuria. Okay, impaired bladder emptying can do that because whenever you have some kind of obstruction, or because this urine flow is an important resistance against these organisms. If you lose this factor, then you can have an infection again. So impaired bladder emptying or decreased urine flow can also cause the cystitis. Okay, and please note, it is most commonly caused by the fecal flora. Okay, all these bacteria will reaches to the urethra through your GIT only. Okay, so the E. coli, Proteus, Klebsiella, they are generally overall the most common causes of the UTI in patients. Okay, so E. coli, the most common one. The second most common is the Staphylococcus saprophyticus. Okay, the third one is the Klebsiella. Okay, Proteus mirabilis can also cause that, and you will also have a staghorn stone, white stone, right? In case of my Proteus, again, Klebsiella can also do that. Okay, so these are all the examples of the organisms that can cause a cystitis in a patient. Okay, these are not the nosocomial one; they are generalized. Okay. So, and please note, they will ask you where does the patient acquire this infection. So please note, this infection is acquired by the fecal flora only. Okay. So I told you one thing, and when we're discussing about the gram positive and the gram negative UTI, I told you that whenever you have the nitrite positive, that always indicate a gram negative organism, and whenever you have a nitrite negative, that always indicate a gram positive UTI. Remember, that means in case of my Staphylococcus and in case of my Enterococci, you will always have a nitrite negative organism. Okay.
Yeah.
Yes.
Again, you will also have a leukocyte esterase positive. That means you have activity of neutrophils in your urine. Okay. And you will call it as sterile pyuria whenever you have all the signs and symptoms of the infection in the patient. Okay, you will be having this nitrite positive, leukocyte esterase positive. But when you perform the urine cultures, you will get a negative urine culture. You cannot see anything on the microscopy. You call it a sterile pyuria. So a pyuria with a negative urine culture, you call it a sterile pyuria. And whenever you have a sterile pyuria, you will always think about two organisms. Most common one is the chlamydia because it is always intracellular, so you cannot visualize it on the microscope. Second one is the Neisseria, which can sometimes be recognized in the microscope when it is extracellular, but because this organism could be intracellular, so sometimes you cannot recognize this. Okay, so chlamydia, Neisseria, they always causes the sterile pyuria, and they cause the urethritis, not the cystitis, by the way. Okay, you will have a discharge from the urethra, and that is a highly characteristic feature differentiating between the cystitis and the urethritis. In the cystitis, you won't have any kind of a discharge, but in case of my urethritis, you will have some kind of a discharge from the urethra, right?
Yes.
So that's about the acute cystitis. For the treatment, you will give the patient most commonly, if it is non-complicated type, you will give the patient trimethoprim sulfamethoxyl or the nitrofurantoin. If it is a complicated one, that means if it is caused by the Neisseria or the chlamydia, you need what to give the patient, and that would be tetracyclines, macrolides, and one more drug. Anyone?
Metronidazole. Next slide.
Yeah.
Cephalosporin.
Not the cephalosporin. What drug you will give to the patient having an Neisseria infection?
Azithromycin.
Not the azithromycin.
Prosophone.
Ceftriaxone.
Yeah, that's one.
Ceftriaxone.
Ceftriaxone.
The ceftriaxone along with either the tetracycline or the macrolides for the complicated type, and for the non-complicated one or a simple UTI, TMP SMX or the nitrofurantoin. Okay, other thing, you can also give the fluoroquinolones to the patient. Okay, those will also work very well. Okay, so that's about the acute cystitis. Please ask it.
Ceftriaxone,
Yeah,
ceftriaxone is third cephalosporin.
yeah, third generation cephalosporin it is. And what was this fourth generation cephalosporin name?
Cephalo, similar name, kind of.
That's right.
Cephalexin.
Cephalexin.
No. I can't remember right now.
Cefepime.
Yes.
And the fifth generation.
Similar. I can't remember now.
Not the similar. Try harder.
Ceftaroline.
Ceftaroline. Yes, exactly. Ceftaroline. And what about cefaclor?
First generation.
No, for the first generation you have cefazolin, cephalexin, cefaclor, phosphor, fat, cefuroxime,
Generation.
cefaclor, second generation,
Yeah.
fake phosphor, these three, right? Cefaclor, cefoxetine, and cefuroxime. Okay. So remember all these generations, these are very important. Okay. They will ask you by giving this example. For example, this fifth generation is not active against this the pseudomonas, right? Only fourth generation and third generation are active against the pseudomonas, right? While all the generation are not active against the MRSA except the fifth generation, right?
Yeah.
So remember about all these generations. These are very important to know. So yeah, let's so come back. So that's about the acute cystitis. Any doubt, please ask.
No, thank you.
Thank you.
So yeah, now what happens when the patient got acute cystitis? Now this infection can reach to the kidney also. Okay, it could be due to a ascending infection. That means if this infection this ascend from the urinary bladder to the kidney via urethra, or second thing is the hematogenous route. Okay, the infection can enter into the blood, and from the blood it can reach the kidney. So by both the ways, this infection can reach the kidney, and in the kidney it can cause the pyelonephritis. So how would you know whether a patient is having a hematogenous spread or the patient is having a ascending pyelonephritis? Anyone?
History of cystitis will be present in ascending type.
Okay, and while the history could be present in both also, or sometimes might not be present if this organism does not infect the urinary bladder and directly affects our kidney by entering into the blood or by this ascending method. So you won't have this history. Other thing,
Blood root often because of a secondary lesion. There will be some primary lesion which is causing infections to fever, those all clinical symptoms.
fever will always present whether you got this hematogenous spread or ascending spread, because it is a pyelonephritis. You will always have a fever.
So there must be some primary source to get the UTI. Like
What primary source we're talking about?
could be anything like any wound, any injury, or a lung infections could be.
No, not like that. I mean, you cannot have this UTI with simple scratch, right? One thing is sure, that the infection first has to reach the urinary bladder. Then only after reaching to the urinary bladder, the infection can reach to your kidney. It has two ways, either the hematogenous or this ascending pathway. So how would you know whether the patient got this pyelonephritis because of hematogenous spread or because of this ascending pathway?
Immunity of the patient may be compromised when it comes to hematogenous spread.
Okay, the one thing is the immunity of the patient. It must be low, yes, in order to invade my blood vessel. Other thing,
Metastasis, some kind of cancer.
I mean, that is a cause of course, your this immunosuppression maybe. Well, see,
Yes.
you can have this. So because of this immunosuppression, you can either have the ascending infection or you can again have a hematogenous, because it is not always be a hematogenous, right? It can be ascending also if you got a low immunity. So not a specific thing. Again, any lab test that you can do, or something. The blood
If-
cultures.
Yeah.
If my bacteria is in the blood, if the bacteria reaches the kidney by the blood, then the blood cultures must be positive, right?
Yes.
So if I do the blood culture, I can have a positive bacteria in them. And plus, because the bacteria is gaining the blood route, there must be a history of sepsis or shock present, right?
Yes.
So
Yeah.
these two things will help you determining whether the patient is having an ascending infection or a hematogenous infection. If it is a hematogenous infection, then blood group must be, this blood cultures must be positive for my bacteria, and patient must be having a history of sepsis or a shock, right? They will have this high heart rate, low blood pressure, and all these things will be there, right? So third important thing is the patient profile. You will only get this hematogenous spread in a nosocomial patient, in a hospitalized patient. Okay, when they have any history of this immunosuppression, or they're very old age, okay, or they're admitted to the hospital with some condition. Okay, so it is always a disabled patient, always a hospitalized patient or a old age patient. Those will get the hematogenous spread. So you will always suspect the hematogenous spread in a patient with a significantly weaker immune response that is seen in the old age hospitalized patient. They will also have a signs and symptom of systemic infection. That means the sepsis will be there. Okay, and because it is spreading through the blood, the patient will also have a positive blood culture. Okay, well, all these things are not present in the ascending pyelonephritis. Is that okay?
Yeah.
Now let's see what symptoms you will get. Now, because it is an inflammation of your kidney, you will have a symptoms which are related to the kidney. So first thing, you will have a flank pain, because it is a flank region where the kidneys are located. Yeah, and does anyone know why you're having this suprapubic pain in case of cystitis? What nerve is causing it?
Inferior hypogastric.
Inferior hypogastric. Yeah, I think, yeah. Inferior hypogastric it is. Good. So it is the inferior hypogastric nerve that is causing the suprapubic pain, and because all these regions are supplied by this inferior hypogastric nerve. Okay, and if you go back to the MSK section, we have discussed all the nerves supplying your lower extremities, right?
Yeah.
All this ilioinguinal nerve, iliohypogastric nerve, right? So remember them also. So yeah, that's why you get a suprapubic pain cystitis. Now let's come back to this chapter again, this part again. So in the pyelonephritis, you will be having first the flank pain. Of course, you will have a systemic symptoms like the fever is always present. Okay, along with all the symptoms of the cystitis, that is the dysuria, frequency, urgency. Sometimes suprapubic pain can also be present, but not most common time. You will have the mainly dysuria, frequency, urgency, flank pain, fever, chills. Okay, so these are all the symptoms patient will present you with in the emergency department. Apart from that, patient can also have a nausea and vomiting. So fever, flank pain, nausea, vomiting, chills, dysuria, frequency, urgency, these are all the symptoms of acute pyelonephritis. And because it is an inflammation of the kidney, once you do the biopsy of the patient, the kidney biopsy, you will find the neutrophils in the renal interstitium. As you can see, these are all the neutrophils in the interstitium of the patient, right? So that you will find on the biopsy of the patient if you perform it. Okay. Now it can have an ascending UTI. It can be because of a hematogenous spread. Okay, hematogenous spread only seen in the hospitalized patient or on the elderly patient, while a young female always have an ascending UTI, and E. coli is the most common, of course. For having an ascending UTI, you need to have a one thing for sure, and it is important. You must have a vascular reflex, because without any reflex, the bacteria cannot pass through the urinary bladder into the ureter, right?
Yeah.
So the patient must be having a history of vascular reflex. It is a must thing. Okay. Now, so this this reflex is always required in order to get a ascending UTI. Okay, patient will have a WBCs in the urine. WBCs in the urine can also be seen in the cystitis. But along with the WBCs, patient will also have a WBC cast. And that is an important thing. Whenever you have a cast, that means it is a kidney pathology. When you perform the CT of the patient, you can see the parenchymal enhancement. Okay, enhancement will be seen, as you can see. This is the parenchymal enhancement that you will see on the CT of the patient. Okay. Now, risk factors include the indwelling urinary catheters, any history of urinary tract obstruction. Okay, these are all risk factors are always same for that of both the cystitis and this pyelonephritis. Same for both. Okay, one more thing is required, which is the vascular reflex, which is always required in order to get a pyelonephritis ascending type. Okay. Now, the complications, patient can get a chronic pyelonephritis, where you have a chronic inflammation in the kidney. You can have a renal papillary necrosis. Okay. Perinephric abscess can also happen, because it is an inflammation. Neutrophils are there. They can cause the abscess also. Okay. Urosepsis can also occur. Okay. If the hematogenous route is present, this bacteria can enter into the blood vessels and it can cause the sepsis there. Okay. Very important. And if the bug is a urease positive bug, then it can also cause the stones, the staghorn stone, right? Stow-white stone.
Yeah.
So these are all the complications you will get with the acute pyelonephritis. Okay. So please note that cystitis or the pyelonephritis, they both originate from the fecal flora. Klebsiella, E. coli, Proteus, Enterococci, Streptococcus, Saprophyticus, all of them are the GI bacteria that can cause the UTI. Okay. And the sexual intercourse always help the bacteria to reach to the bladder. Okay, with the sexual intercourse, they can reach to the bladder and there they can cause a cystitis. If the patient is also having a vascular reflex, then from the bladder, this infection can also ascend upward into the ureter and can reach the kidney, and it can cause the pyelonephritis also. Okay, a normal vascular junction never allow the bacteria to reach to the kidney. It must be disrupted. Okay, and yeah, that's all about the acute pyelonephritis. Any doubt, please ask.
No, thank you.
No, thank you.
Second you have is the chronic pyelonephritis, and because it is a chronic inflammation, you will have a lymphocytes, right?
Yes.
So one thing is you will have a lymphocytes. You will have both the lymphocyte B type as well as T type. Plasma cells will also seen in the chronic pyelonephritis, which is not seen in the acute type. Having having the plasma cells always signifies a chronic inflammation. Okay, it happens because of a inadequately treated acute pyelonephritis or a recurrent episodes of acute pyelonephritis. Okay, patient must be having a history of vascular reflex or a chronic obstruction in the kidney. Okay, now what you will find on the on the examination of a patient, on the kidney examination, you will find a coarse, asymmetric. Okay, yeah, see, you will find this coarse and the asymmetric corticomedullary scarring and the blunting of the calyces. This is the important part. You will have a blunting of the calyces. Okay, that tubules will always will also contain the eosinophilic, or you can say a pink material that can resemble the thyroid tissue. If you look here, this tissue is resembling the thyroid, right? You have this diffuse pink homogeneous the type of thing same in the thyroid gland also, right? In this circular form, all these. Remember the thyroid follicles?
Yes.
They are circular and they have this homogeneous pink material inside them. Okay, so that type of thing also found in the chronic pyelonephritis. It can resemble the thyroid tissue, and that's why it is known as the thyroidization of the kidney. Okay, so asymmetric kidneys will be there. Okay, you will have a broad scarring and the blunting of the calyces. Okay, and please note the upper and the lower poles of the kidney are most commonly affected. Just like we have discussed previously, whenever you got any obstruction, Okay, because of this vasodilator reflex, remember?
Yeah.
In the vasodilator this reflex, you will have a upper and lower pole atrophy and the scarring of the whole kidney and the shrinking of the kidney, right?
Right.
Same thing again you will found in the chronic pyelonephritis also. You will have a atrophy of the upper and lower poles, scarring of upper and lower poles. Okay, improper shape of the kidney will be there and atrophy of the kidney will happen. These are all the findings on the examination on the CT of the patient you will found. On the biopsy, you will find this thyroidization of the kidney. Okay, now thirdly, you will have, which is a form of this chronic pyelonephritis, it is the xanthogranulomatosis pyelonephritis. Okay, and this can mimic a tumor nodule. You will have the granulomatous tissue in them. That means you will find the granulomas in the tissue, in the kidney. And whenever you see these kind of granulomas in the tissue, forming macrophages, you will always think about the xanthogranulomatosis pyelonephritis. As the name suggests, you will have the granulomas in them. Okay, and you will again have a very widespread kidney damage, not a localized, not a focal one. It will be a generalized diffuse kidney damage will be there. Okay, nodules in the kidney will be found. And I told you, whenever you have nodules in a tissue, it will always mimic a metastasis of a tumor, remember? Like in case of my brain, you will have these nodules. In case of my lung, you will have this canal ball appearances. In my liver, you will have all these nodules, multiple nodules, right?
Yes.
So same thing goes for the kidney. Whenever you have a metastasis in the kidney, you will have multiple nodules. And that's exactly what's seen in the xanthogranulomatosis pyelonephritis. You will have a grossly orange nodules, and it will look like that the tumor, that the kidney is having a metastasis. Okay, a tumor on these nodules. You do the biopsy of the patient of these nodules. What you will see are the granulomatous tissue, and you always think about the xanthogranulomatosis pyelonephritis. And please note, it is associated with the protease infection. Any doubt, please ask.
No, thank you.
So that's about my UTIs. Okay, you have the cystitis, you have the pyelonephritis. Please note how to differentiate between a cystitis and the pyelonephritis. Presence of fever, chills, flank pain, nausea, vomiting, it means pyelonephritis. Presence of just the dysuria, frequency, urgency, suprapubic pain, it will be the cystitis. You need to also know how to differentiate between a cystitis and the urethritis. And you will look always for the discharge history. If a discharge is present, then it means it is a urethritis. If a discharge is not present, that means it is a cystitis. You know what is the most common factor or the most important factor that you need in order to get a pyelonephritis, and that is a vascular reflex. Two pathways, this hematogenous pathway or the ascending pathway. Ascending pathway for the young female and hematogenous spread for a old age immunocompromised patient. History of shock is also very important. Blood culture history is also very important in the hematogenous spread. For the chronic pyelonephritis, again, you will need to have a vascular reflux. Okay, that will cause a thyroidization of the kidney. You will have a lymphocytes, scarring, blunting of the calyces, upper and lower pole will die first, atrophy of the kidney will see. That's all the findings in the acute and chronic pyelonephritis. Okay, now you have the acute kidney injury, or you can say acute renal failure. Okay, that means a sudden drop in the GFR will see. Patient will be having a high level of creatinine in all of these diseases. In all of this condition, patient will have a high creatinine. Okay, low excretion of the urine. That means oliguria will be present. Low GFR will be present. Okay, and the patient will also have a history of edema because of the urinary failure in all of these diseases, right? So it is a form of acute renal failure or acute kidney injury. Your kidneys are dying because of that, right? So first you have the pre-renal azotemia, second you have an intrinsic renal failure, and third you have a post-renal azotemia. Now, as the name suggests, the pathology always lies pre-renally. You're having an azotemia or a kidney failure, all this high level of this BUN or this uremia because of a damage that is happening proximal to the kidney. Okay, and because of this damage, the kidneys are also suffering. It can be happen because of hypovolemia. It can happen because of a low cardiac output. It can happen because of a heart failure. It can happen because of a liver failure. So all the diseases, all the conditions which can cause a shock in the patient, disruptive shock, septic shock, hypovolemic shock, okay, hemorrhagic shock, that means a low cardiac output in that case, okay, liver failure, which can cause a ascites and this portal hypertension, heart failure, which can cause a decrease in the urine out this cardiac output. In all of these conditions, you will have a decreased flow to the kidney, and because of a decreased blood flow to the kidney, you will have a hypoxia in the kidney that causes a damage in the kidney. Now, I told you whenever you have a decreased blood flow to the kidney, two things will happen. One is the ADH, and second is the RAS, right?
Yes.
Now, because the ADH got activated, you will have a free water reabsorption as well as a urea reabsorption. Now, because of this increase in the urea absorption, you will have a high BUN in the blood. And once you do the ratio of the BUN to creatinine, you will find a ratio more than 20 because of excessive increase in the reabsorption of the BUN. Because the RAS is activated, you will have a reabsorption of sodium also. And that's why the fractional excretion of the sodium is less than 1%. Okay, because of the reabsorption of the sodium, you will have a low sodium in the urine, which is less than 20. Because it is a hypoxic condition, kidneys are not getting enough fluid. They will have a more reabsorption of the fluid, and as a result, your urine become very much concentrated. Okay, the osmolality of the urine is more than 500 because of a dehydration condition. Whenever you have a dehydration, you will find your urine will have a very high concentration, right? So the osmolality always more than 500 because of low water content in the urine. And as a result, you will always have the specific gravity of the urine around 0.015 to 0.000. Okay, you will have a normal urine specific gravity between the 0.003 to 0.000. Okay, you will call it a concentrated whenever you have the specific gravity more than 0.015. Okay, and the specific gravity which is near 0.030, it means the patient is having a pre-renal azotemia. And I told you, whenever you have a concentrated urine, you also have one cast in it, one type of cast. Remember the name? No one? What cast you will find whenever you have a this concentrated urine? We discussed it in the
Highline cast.
cast. Yeah, highline cast you will see. So in all the conditions, whenever you are having a renal azotemia, they will always mention you that the patient is having a highline type of cast. Okay, it happened because of a dehydration. If the dehydration becomes severe, if all of these causes become very much severe, they all can cause an intrinsic renal failure also, because in all of these causes, the kidney is overcoming somehow by increasing the RAS, by increasing the ADH. Okay, the kidney is trying to manage somehow. But if these conditions become severe, if you have a severe heart failure or a severe shock is there, in that case, the necrosis of the kidney will happen. Ischemia and necrosis, right?
Yeah.
Yes.
And that will lead to an intrinsic renal failure also. So all of these causes can cause a intrinsic renal failure also. Is that okay?
Yes.
Yes.
So that's about the pre-renal azotemia. Because of hypovolemia, you will be having a history of hypotension. Because of low cardiac output, you will be having a low BP. Okay, it could be not dependent upon the cause. You will either have a high heart rate or a low heart rate. Okay, and you will also have a decrease in the capillary filling time. Oh, sorry, increase in the capillary filling time will be there, right? So look for the symptoms of all these diseases. Look for the oliguria. Look for the high BUN creatinine ratio. Look for this high creatinine count also. Okay, you will know the patient is having a pre-renal azotemia. Any doubt, please ask. No. Now the second is intrinsic renal failure. In all of these conditions, you will be having a damage inside the kidney, not before the kidney, not after the kidney, but inside the kidney. Okay, it can happen because of a tubular damage or an interstitium damage. That's exactly what happens in the acute tubular necrosis. You will have a necrosis of the tubules, and as a result, the tubules are not functionable now. Okay, your kidney will be losing all of the fluid because it cannot reabsorb it. Okay, the sodium will be losing. Okay, the urea will be losing. Okay, the fluid will be losing from the kidneys, from the ischemia, from the sepsis, from the infection. okay, from the nephrotoxins, they can all damage the tubules directly. You will have a tubular necrosis because of that. Acute interstitial nephritis, where you have an interstitial inflammation in the kidney, okay, which is the space between the different nephrons. Okay, you will be having an inflammation there, and that can again cause a intrinsic renal failure. The kidney will no longer be functionable as long as you have the inflammation inside it, right? The glomerular causes includes the acute glomerulonephritis, in which you're having an inflammation of the glomeruli, and as a result, I told you will having a low GFR, high creatinine, edema will be there, right? So all of them, and ultimately, I told you that all of these diseases can progress to a kidney failure. Remember?
Yes.
Yeah.
So they can cause a kidney failure again. Now, vasculitis can cause it. Malignant hypertension that can damage the renal vessels. It can also do that. The TTP-HUS syndrome. Remember the full form of this disorder?
Thrombotic thrombocytopenic purpura,
And HUS?
hemolysacchuremic syndrome,
Yeah. What causes a hemolytic uremic syndrome?
Shigella, and E. coli O157H7.
Yeah, EHAC. And the TTP is caused by?
Autoimmune.
Yeah.
Autoimmune.
What's? Sorry, I couldn't understand.
Consumed platelets.
Yeah, consume platelets. Of course, you're gonna have a microthrombosis, and that's why they consume platelets. But what is the causing? What causing this TTP? The pathology. Any mutation? Yeah, Adam TS13. Okay, and the Adam TS13 functions to clear the von Willebrand factor. Okay,
Can you
because
repeat, please?
yeah. Ask.
Can you repeat it?
See, you're having a deficiency of the Adam TS13, ADAM TS13.
Yeah.
Now,
Yeah,
because of this
okay.
deficiency, you will be having you cannot degrade the von Willebrand factor, and as a result, it will activate the platelets to cause the microthrombosis. So you will be having a microthrombosis in the kidney vessels, in the blood vessels supplying the kidneys, and as a result, that will damage the smaller vessels in the kidney. So a part of the kidney, smaller part of the kidney will die in case of this TTP-HUS, and as a result, you will be having a intrinsic renal failure because of that. Okay.
Okay.
Now, because your kidney is dying now, okay, it is basically a damaging. This damage is happening inside the kidney. The kidney cannot work properly. They cannot compensate for that. They will be having a loss of function. They cannot reabsorb the sodium, and as a result, you will be having an increased loss of sodium. That means an increased excretion of the sodium more than 2%. Okay, you will be having a more sodium in the urine more than 40. Okay, because your kidney now cannot concentrate the urine, they cannot reabsorb the water, so they cannot concentrate the urine. You will be having a low osmolality of the urine. Okay, this BUN now cannot be reabsorbed properly because ADH is not functionable. So you will be having a low ratio of the BUN and creatinine, that is less than 15. And the creatinine will be elevated significantly because you're having a loss of GFR also, right? Because of this, all this debris is now blocking the tubules. You cannot have the filtration, because I told you, whenever you have a blockage in the tubules, it will raise the hydrostatic pressure in the Bowman's space, right?
Yes.
So that will cause a decrease in the filtration. You will have a loss of GFR. Significantly low GFR will lead to a significant rise in the creatinine also. You will have a creatinine
Yes.
level of more than 2 or 3 even, and the ratio will be less than 15 always. So these are all the findings we will see on the analysis of the patient. Okay, a very low, or you can say a very dilated urine. Okay, a very high urine sodium, a very increase in the fractional excretion of the sodium. Okay, high creatinine, a normal to low, or sometimes a raised even BUN, because ultimately you're having kidney failure, so this uremia will be there. But the ratio is always less than 15. That is an important thing. All these risk factors must be present in the patient. They will always give you any history of any of this disorder. Okay, and please note, it will be a patchy necrosis in the kidney. Okay, so that's everything. So what could be the specific gravity of my urine in case of intrinsic renal failure?
Low specific
Can you
gravity.
repeat that question?
Specific gravity of urine. If you test the specific gravity of the urine in case of intrinsic renal failure, what would you find?
Low specific gravity.
Yeah, low specific gravity, which is near 0.003. Okay, because our kidney cannot dilute your urine now. So less than 350 osmolality and around 0.003. It would be between 0.003 to 0.015. Okay, that you will find on the specific gravity of the patient. Any doubt, please ask.
No.
Why,
No,
I-
thank
why,
Yeah.
why is it gravity? I don't understand how you're getting specific gravity for intrinsic renal failure.
Why this?
I thought
What is the meaning of this specific gravity?
the concentration of the urine. So
Exactly.
is it
If
just saying that with intrinsic renal failure, it's not able to do its job? So you're gonna have as dilute as urine as you
look
can?
at this, urine osmolality. How much it is? It less than 350.
Yeah.
Right? You cannot concentrate your urine, right? And that's why you're having a very low urine osmolality. And if you cannot concentrate your urine, then you will always have a low specific gravity, right?
Okay, no, the reason I got confused is because on pre-renal azotemia, it's, oh, okay, never mind. I understand
the-
now.
In the prerenal azotemia, your kidneys are working fine. They're just managing somehow all these causes, right?
Yeah, no, I misread. I read it as 003, not 0.03.
Ah.
Now I understand. Thank you.
So in case of my prerenal azotemia, my kidney are still working. And all of these findings that you are seeing is because kidney are trying to compensate for the loss of blood. In this case, in case of my intrinsic renal failure, you're finding all these things because your kidney are not functioning now properly. So they're losing all this water, all these electrolytes and other things. Okay.
Thank you.
Now, third one is the post-renal azotemia. It happens because of a blockage in the outflow tract of the urine. It can happen because of stones, because of BPH, because of neoplasms, because of congenital anomalies. So all of the risk factors that we have discussed for the hydronephrosis, the BPH, stones, obstruction, cancer, this injury, ureteroparenteral fibrosis, vesicular reflux, all the causes we have discussed for this overflow incontinence, the diabetes, BPH, multiple sclerosis, all of them can cause the post-renal azotemia. Okay.
Okay.
And again, your kidneys are now not functioning properly, so you will be having a osmolality of less than 350, and rest all the findings are very much variable. Okay, they could be high, they could be low, they could be anything. So just look for the osmolality less than 350. Look for the history of the patient. He must be having a pain that is leading to the groin, a recurrent pain. Okay, they could be having a history of low flow of the urine. Okay, or weak stream of the urine. They could be having this kind of a history, or a history of continuous dribbling could be present, overflow incontinence. They could be having a history of any cancer. Okay, it could be cervical cancer, it could be a cancer of the prostate, it could be a congenital problem. So the patient will be a young, okay, a teen patient could be there, right? The patient could be having a history of any chemotherapy or the radiotherapy. So look for this kind of a history. They will help you determining the cause of this post-renal azotemia, because these findings are very much variable, so they won't help you determining the exact cause. Okay. Okay.
Yes.
Okay.
Now, what we'll find on the gross examination of the kidney in a patient having post-renal azotemia?
Enlarged kidneys.
Yeah, we will have a hydronephrosis, not the enlarged kidney, but the dilation of this calyces and the
Urethra.
yeah. So you have a dilation in the kidney, inside the kidney, but ultimately atrophy of the kidney will be happening, right?
Yeah.
So that you will find on the post-renal azotemia. Now, please ask if there is any doubt in the acute kidney injuries.
No, thank you.
Okay, so let's take a short break then.
Yes. Thank you.
Okay.
Okay, so we have discussed up to all these kidney injuries, different type of kidney injuries that you can happen, the perineal azotemia, intensive renal failure, or the post-renal azotemia. We have discussed you will get acute loss of kidney function in these cases. You will have a sudden rise in creatinine, BUN levels. In some diseases, you can have a loss of sodium. In some, you can have a reabsorption of the sodium, right? So let's discuss the causes of the intrinsic renal failures. And the first one is the acute interstitial nephritis. So as the name suggests, you will be having an interstitial nephritis. That means the inflammation in the interstitial space of your kidney. And that is a space between the different nephrons. Okay, you have this cortex medulla. In the cortex medulla, you have all these nephrons. And in between the nephrons, you have some space, and we call it an interstitial space. Okay, so in case of my acute interstitial nephritis, you will be having an inflammation of this interstitial space. You also call it a tubo-interstitial nephritis. Okay, so it will be a acute interstitial renal inflammation. Okay, again, you will be having a signs and symptoms of the inflammation like the fever. Okay, apart from that, patient will also have a rash in this condition. Okay, a generalized kind of a rash will be there. So a fever, rash, hematuria will be there because it is affecting your kidney. It will be inflammation of your kidney, so you'll be having a blood loss. Okay, so hematuria, pyuria will be there. That means you will be having a WBCs in your urine. Okay, a costovertebral angle tenderness will be seen, or you can say a flank pain can also be seen. So a patient having a fever, rash, hematuria, pyuria, costovertebral angle tenderness, and that all happened after a drug use. Okay, this acute interstitial nephritis is generally happen after a drug use. Okay, this drug could be an diuretic. It could be a NSAID. It could be a penicillin derivatives. Okay, like all these fluoroquinolones. Oh, sorry, the cephalosporins. Okay, all the penicillins, the beta-lactam drugs, you can say. All the beta-lactam drugs can do that. Okay, proton pump inhibitors, rifampin, fluoroquinolones, sulfonamides. They are all can cause the acute interstitial nephritis. So it would be a patient having a recent having a history of recent starting of some kind of a drug. It could be a diuretic, NSAID, cephalosporin, penicillins, proton pump, rifampin, sulfonamides, fluoroquinolones, any kind of a drug it could be. After using drug, within a month, the patient started having this fever, rash, hematuria, pyuria, and costovertebral angle tenderness. Oligouria will be there. That means a low urine output will be seen. Okay, so whenever you see this kind of a presentation, you will always think about the acute interstitial nephritis. Okay, so it is an acute it is an acute kidney injury that happens after the administration of a new drug. The symptoms should be happen within a month of the initiation of the therapy. It generally happens after a week. Okay, 1 to 3 weeks is a time. Okay, so whenever you encounter a patient having a renal injury after starting of a new drug within a month, think about the acute interstitial nephritis. On the urine analysis, you will find the WBC cast, and see only in two conditions you can have a WBC cast. One is the pyelonephritis, and second is the acute interstitial nephritis. So whenever you see a question giving, whenever you see a question giving you a WBC cast, okay, two things must come in your mind. One is the pyelonephritis, and second is the acute interstitial nephritis. Okay, so WBC cast will be there. It could be it will be a sterile pyuria. You won't find any bacteria, just the WBC cast, and this sterile pyuria will help you differentiating between the pyelonephritis and the acute interstitial nephritis, because in pyelonephritis you will be having some bacteria in the urine also. But in case of my acute interstitial nephritis, you won't have any bacteria, just the WBC casts. Okay, and please note that WBCs are the eosinophils in that case, because it is a hypersensitivity reaction against a drug. Okay, you will be having a eosinophils also. Okay, so you will be having a eosinophilic cast in the urine analysis. So a patient with fever, rash, eosinophilia, eosinophilic cast in the urine, hematuria, flank pain. Think about after starting of a new drug, think about the acute interstitial nephritis. Other than drugs, it can happen because of infections also, and generally infections are this mycoplasma. Autoimmune diseases can also do that, and these are the Sjogren syndrome, SLE, and the sarcoidosis. Okay, they all can cause the acute interstitial nephritis. And if the step one asks you what kind of a hypersensitivity it is, you will say it is a type 4 hypersensitivity, although you're having the eosinophilia and the eosinophils in this case, but it is a type 4 hypersensitivity reaction. Okay, do remember this fact also. So a patient with a recent history of diuretics, antibiotics, NSAIDs, PPI use, and now he's having a fever, rash, eosinophilia, oliguria, flank pain, and WBC cast, sterile pyuria, eosinophilia. Think about the acute interstitial nephritis. Any doubt, please ask.
So is the fact that it's type 4 hypersensitivity because of the hapten?
No, happening can be happen in any case. In the type 1, type 2, type 3, type 4, in all of these scenarios, you need some antigen, right? And that is a hapten. This you call it the smallest antigen, right? Hapten is nothing but a smallest antigen that can the drugs can have. Okay. So hapten can be present in any of the hypersensitivities.
Why is this considered a type 4 hypersensitivity?
Because you have the lymphocytes also in this case. Macrophages, lymphocytes are also present. Although you're having a eosinophilia, I know, but it is a type 4 actually. And you know, the time is also very important. You won't have this, you know, the type 1 will always be there as soon as you take the drug, right? You take the drug and within hours you have this hypersensitivity for a type 1, right? The time period is also very important. But in this scenario, you can see the time period is 3 weeks. Okay, and it generally seen only in the type 4 hypersensitivity reaction. Remember? I told remember all this time frame of these reactions.
Okay.
So because it's taking so much time, you can think that it could be a type 4. Because if it is a type 1, it must be happen immediately after drug therapy, within hours only.
Okay, thank you.
Okay, so that's about the acute interstitial nephritis. Any more doubt, please ask.
Is those drugs cause it because it's renally excreted or does not matter?
So they are all the renal toxic drugs they are. That's why nephrotoxic drugs. Okay, that's why they are causing it.
They are nephrotoxic because they are renally excreted or not?
Some of them are renal secreted, some of them are not. Okay, so that's not the important thing to remember. Okay, it's not important to know whether they're excreted by kidney or not. It's just they're toxic to the kidneys.
Okay. Thanks.
And like I told you already, you will have some low, I told you already, you can have some low molecular weight proteins in the kidney in the ultrafiltration, but the kidney reabsorb them completely, right? Remember, I told you, you will have some filtration of the proteins which are having this very light charge or a low molecular weight or a very small size. They can be filtered.
Yes.
Right, but the kidney reabsorb them completely. Okay, so you won't find these proteins generally in the urine. These proteins could be found in your urine whenever you have an excessive amount of these proteins. For example, in case of multiple myeloma, you will be having an excessive light change, right? In that case, you would be having these proteins in the kidney. Okay.
Yes.
And whenever you have any kind of a damage to the tubules or your glomerulus, you can have the proteins again, right?
Yeah.
Yes.
Yes.
So a tubular proteinuria can occur whenever the PCT function is disrupted, you know, because these filters, these proteins are generally filtered, they need to be absorbed in the PCT. If the PCT become dysfunctional, for example, the Fanconi syndrome, then you can have a loss of all these smaller proteins in the urine also, right?
Yes.
And you know, this proteinuria can also be present in the acute interstitial nephritis one. So please remember that fact also. Okay. In the ischemic tubular damage, you can have this proteinuria. Okay. In the interstitial nephritis, you can have this proteinuria also. Okay. So why this proteinuria is happening? Because your PCT is not functionable now. Okay.
Okay.
Remember these two facts also. Then, yeah. Okay, now if you give the patient diuretic therapy or the ACE or ARB therapy, in both the cases, you can have a high level of creatinine and the BUN, right? No? Yeah. In both the cases, if you give the patient diuretic or you give the patient ACE ARBs, you can have high level of creatinine if you have any blockage. For example, see a case of a renal blockage. If you give the patient ACE or ARBs, in that case, they will cause the dilation of the efferent arterioles, and you will be having a low GFR because of that, right?
Yes.
Yes.
So they both can increase the BUN and creatinine. They both can decrease the GFR, because in case of diuretics, you'll be having a fluid outflow, right? You'll be having a dehydration kind of a status. In that case, they can also cause the high creatinine, low GFR other cells, right? So how we differentiate whether the patient is having, this high level of BUN due to a diuretic therapy or because of a ASAP therapy? It could be a patient having a history of hypertension. You gave him some drug, and now the patient is having a high BUN. So how would you differentiate whether this high BUN level, high creatinine level is because of a diuretic therapy or because of a ASARB therapy?
Do we look at the osmolarity of the urine?
Okay, the one thing is the osmolarity. Yeah, we can try this. Other thing,
Check for blood pressure because
blood
diuretic.
pressure. Yeah, blood pressure is very important to note. Other thing,
You will have hypokalemia with a diuretic.
okay, hypokalemia is also important. And the sodium also, because generally you measure the sodium, not the potassium levels in the urine, right?
Yes.
So the sodium levels you need to measure. See, if you give the patient diuretics, okay, then because of this fluid loss, the BP would be normal to decreased. Is that okay? Because you're losing your fluid.
Yes.
Yes.
And because you're losing your fluid, you can have a pre-renal azotemia state. Is that okay?
Yes.
So in that case, the sodium loss will be decreased. You'll be having a sodium loss less than 20. If you give the patient ACE or ARB therapy, okay, they can increase the BUN and creatinine, and in that case, you'll be having a loss of kidney function also. And that's why the sodium loss in the urine will be increased. It is more than 20. Okay.
Yes.
So note that fact. In that diuretic therapy, it will be same as having a pre-renal azotemia. But in case of my ASR therapy, you can have a high BUN creatinine levels, and that's because of a kidney dysfunction. So that's why you'll be having a high sodium loss. Okay, you will be having this a baseline hypertension would be present in the patient also, of course. So a patient having a baseline hypertension, sodium loss in the urine, that means the loss will be more than 20. You will find. So the fecal excretion of the sodium, the fractional excretion of the sodium will also be increased. It will be more than 2%. You will see. So ultimately, findings will be similar to that of intrinsic renal failure, right?
Yes.
So if you see the findings with intrinsic renal failure, think about the ASAP therapy. If you see the findings similar to that of pre-renal azotemia, think about the diuretics. Okay, that's why differentiate between a rise in BUN because of diuretic and because of ASAP. Okay.
Okay.
So that everything on this page. And any doubt, please ask on this page.
And that's just with normal use, right? That's not with an overdose overdose activity.
Yeah, it is normal. Yes. Okay. Yeah. Any more doubt?
No, thank you.
Now, the second cause of intrinsic renal failure, and that is acute tubular necrosis. Okay. In this case, as the name suggests, it will be an inflammation. It will be a necrosis of your tubules of the kidney, of your nephrons. And as a result, you will be losing your kidney functions. And does anyone know what are the functions of my kidneys?
Vitamin D formation.
The primary functions, the majority function, the major
Filtration.
functions, the
Filtration.
filtration. Yeah, the electrolyte balance, one thing.
Erythropoietin.
Erythropoietin, second thing, okay.
Activation of vitamin D.
Balance.
Hydroxylation.
It is a minor. See the major functions of my kidney that will be visible shortly.
acid base, the balance.
Whenever my kidney fail, what are the first symptoms I will see of my kidney failure? You know,
When
all this
creatinine,
majority of the functions. Yeah.
Edema.
Fluid overload.
creatinine
The
goes
fluid,
up.
yeah. The fluid balance, one thing. Electrolyte balance, second thing. Osmotic balance, third thing.
Acid.
Acid balance, fourth thing, right?
Uremia. Yes.
Yeah. These are the 4 major functions my kidney perform, right? And whenever these 4 functions are lost, I will say that my patient is having a kidney failure, right?
Okay.
So in case of my acute tubular necrosis, you will be having an acute kidney failure. And because of that, all of these functions are now lost. Okay.
Yes.
Yes.
My kidney cannot maintain the electrolyte balance. My kidney cannot maintain the hydration. My kidney cannot maintain the osmolarity. My kidney cannot maintain the acid balance, right? So the key finding, okay, the pathognomonic thing that you will see whenever you encounter a patient having an acute tubular necrosis is the muddy brown cast or the granular cast. You will see all of these are the granular or the muddy brown cast, and these are specifically seen in the acute tubular necrosis. Okay, these casts consist of all the necrosized material, all this necrotic material of the tubules. Okay, they form this cast. So it is a pathognomonic for the acute tubular necrosis. It consists of 3 stages. Whenever you have an acute kidney injury, you have 3 stages. One is the inciting event. Okay, and the inciting event could be any of these risk factor. It could be ischemic. It could be a nephrotoxic event. Ischemic event include any case of a shock. It could be a hypovolemic shock. It could be a septic shock. It could be a hemorrhagic shock. It could be due to a heart failure. So any cause of prerenal, I told you, whenever you have a prerenal azotemia, if it becomes severe, it can lead to a necrosis of the kidney, remember?
Yes.
And because of that, you can also have a intrinsic renal failure. So all of them can cause the intrinsic renal failure. So these are the inciting events. Okay. Similarly, nephrotoxic events, for example, the aminoglycosides, I told you these are nephrotoxic drugs, antibacterials. Radio contrast, whenever you perform the CT or MRI of the patient, you ask them to swallow this contrast, right?
Yes.
Yes.
And whenever you swallow this contrast, okay, they can have a damage to the kidney also because of that. Okay, so it will be a patient who is recently undergoing the CT or MRI, and now he is having this acute kidney injury. Okay, lead can do that. Cisplatin can do that, which is a, what kind of a drug is it?
Anti-cancer.
Anti-cancer, chemotherapeutic drug, right? And what category? Cisplatin, carboplatin?
Platins.
The platinum containing drugs. And I told you they can cause the kidney damage, right? They're nephrotoxic. While you have one which causes cystitis, one chemotherapeutic agent that can cause cystitis.
Cyclophosphamide.
Yeah, cyclophosphamide, right? So the cyclophosphamide can cause the cystitis, and the cisplatin carboplatin can cause the tubular necrosis. Okay, ethylene glycol, which is an antifreeze, that can cause the oxalate stones also, right? Remember?
Yeah.
So this can also cause the acute tubular necrosis. Crush injury, whenever you have a damage in your muscles due to any drug or due to any trauma. You can have a myoglobinuria, and I told you the myoglobin is very toxic to the nephrons. It can cause the acute tubular necrosis. Hemoglobinuria can also do that, which can happen in the paroxysmal nocturnal hemoglobinuria or any cause of the, this intravascular hemolysis. Whenever you have an intravascular hemolysis, you will always have a hemoglobinuria, right? The hemoglobinuria, hemosideruria, remember?
Yes.
So all of the causes of this intravascular hemolysis, they can cause the acute tubular necrosis. Okay, so first you have this inciting events. That could be any of these. After this inciting event, you will have a maintenance phase. In this maintenance phase, kidney cannot perform its function. You will be having a oligouria. First thing, because the filtration will be inhibited. Okay, you cannot have the filtration, so you cannot have the urine. Oligouria will be there. Okay, you will be having a hyperkalemia. Okay, because the function of kidney to secrete the potassium and to cause the reabsorption of the sodium, remember?
Yeah.
Electrolyte balance, you cannot have electrolyte balance, and as a result you will be losing all the calcium, you will be losing the sodium. Okay, you'll be losing the bicarbonate. okay, that causes the metabolic acidosis. You'll be having a reabsorption of the potassium that is causing the hyperkalemia. Okay, you cannot have the acid-base balance, metabolic acidosis, and the uremia will be there. So what kind of a metabolic acidosis it would be?
Normal anion gap.
No, yeah, no,
Why normal anion gap?
because no extra acid.
Why you're having a uremia, extra
Yeah,
addition of
yeah,
acids,
anion
multiple
gap. This anion gap
Would be-
metabolic.
it will be an anion, high anion gap metabolic acidosis. Okay,
Because of
so
acid.
yeah, exactly, because you cannot excrete the acids now.
Yes,
Okay,
yes.
so these are all the things you will find in the patient. So whenever these things are present, you will say the patient is having an acute tubular necrosis. Now comes the recovery phase. In the recovery phase, the glomeruli become functionable even before the tubules can achieve their function properly. Okay, before the tubules become normal, the glomeruli start functioning. So the hyperfiltration will be there. Okay, GFR will be increased, but your kidneys cannot reabsorb the fluid now. And as a result, all of that fluid will be losing in the urine. So in the recovery phase, in the maintenance phase, you will be having an edema because you cannot have this GFR. Okay, but in the maintenance, in this recovery phase, you can have the GFR, but you cannot reabsorb this fluid. And as a result, the patient become polyuric. Okay, all of the BU and all of the creatinine, it will be losing from the kidney. You cannot reabsorb it because tubules are still not functionable. So in this case, you will be having a low level of BU and low level of creatinine. Okay, the ratio will be of course less than 15 because it is an intensive renal failure. You will be having a hypokalemia now. Instead of hyperkalemia, you will be having a hypokalemia now because tubules cannot reabsorb anything. Okay, all the electrolytes, including sodium, calcium, potassium, they will be losing from my body. Okay, any doubt in that part up to here?
No, thank
Could
you.
you repeat the 3 stages again?
See, in the first stage, inciting event, any of this risk factor can cause this inciting event. After this inciting event, within 24 hours, patient will have this maintenance phase in which your this glomeruli and as well as tubules are not functioning properly. So you will have a fall in the GFR. As a result, you will become oligouric. Patient cannot have the this urination. So it would be a patient who is not maturated for 24 hours. You will think about this oliguria. Hyperkalemia will occur because aldosterone is not functionable because I told you this electrolyte balance will be lost. So loss of sodium, loss of calcium will be happening, and absorption of the potassium will be happening, will become hyperkalemic. Okay, losing loss of this bicarbonate and addition of extra acids happen. That means the metabolic acidosis with uremia, you will be having a high anion gap metabolic acidosis.
Yes.
In the recovery phase, this glomeruli will attain its function at a very early stage, but the tubules are still not ready for the reabsorption. They are still not normal. So you'll be having an ultrafiltration, but this GFR, whatever the fluid filtered through this GFR, it cannot be reabsorbed in the tubules now. So it all will be losing from my tubules. So this patient will become polyuric, dehydrated. This can also happen. Dehydration can also happen. BU and creatinine will be falling. Hypokalemia, hypomagnesemia, hypocalcemia, hyponatremia. All of these things will happen.
Okay.
Okay.
Got it.
These are the findings you will see. Now, when you do the biopsy of the patient in the maintenance phase, you will see the PCT cells ballooning. That means a swelling of the cell, which is a sign of reversible or this injury. Okay, vacuolar degeneration will also happen. It will become multiple vacuoles inside the tubules. So you see the vacuoles, you see the swelling of the cell. That means the patient is still in the maintenance phase. In the recovery phase, you will see the tubular reepithelization. Okay, that means the regeneration of the tubules is happening in the recovery phase, and that's why the name recovery, because we have the intact stem cells right now. Okay.
Yes. Yes.
So these are the biopsy finding in the maintenance phase. It will be the ballooning and vacuolar degeneration. In the recovery phase, it will be the tubular reepithelization. Okay, patient won't have any gross hematuria. There won't be any papillary necrosis. Okay, so please note, in the acute tubular necrosis, there won't be any hematuria, no RBC. In case of my interstitial nephritis, you will be having a RBC, right? Hematuria will be there.
Yes.
But in case of my acute tubular necrosis, no hematuria, because kidney lost its function. BUN creatinine level will be less than 20. Excretion of sodium will be increased more than 2%. Urine sodium will be more than 40, as you already know, the intestinal renal failure. Okay, the problems are lie in the tubules, not in the glomerulus. If the problem lie in the glomerulus, you will be having what?
Glomerulonephritis.
Glomerulonephritis. Okay, but in this case, it will be a tubular necrosis. So different things. Okay.
Yeah.
So whenever you have a ischemic damage, okay, those portions of the nephron which are highly those portions of the nephron which have a very high metabolic demand, they will die first, and these are the PCT and the ascending loop of Henle. Whenever you have a nephrotoxic damage, the PCT is the initial portion and it will die first. Okay, so in both the conditions, PCT is dying. In case of my ischemic damage, both PCT as well as ascending limb will die first, because these are the watershed zones, or you can say, they have a very high metabolic demand, so they will die first. Okay.
Yes. Yes.
So, any patient who is having a recent history of infection and now having an acute tubular necrosis, any patient who is undergoing a CD or MRI and now 24 hours later he become oligouric for 24 hours, no urine output for 24 hours, think about the acute tubular necrosis. Any patient who is working on a on a munition factory, or maybe a paint, okay, or maybe a construction worker, think about the lead poisoning. A patient on a chemotherapy and now he's having an acute tubular necrosis, think about that. Any patient who is very alcoholic and now having a kidney injury, think about the ethylene glycol poisoning. Patient who is having a recent history of trauma within 24 hours, okay, a recent accident, for example, okay, they will be having a myoglobinuria, they can have a crash injury. Okay, a patient having an intravascular hemolysis, they can have a this ATN due to hemoglobinuria. Okay, so all of these are the causes of these things. Okay.
Yes. Yes.
So yeah, that would be all about it. And in the maintenance stage, the patient become oligouric, urine output will be decreased, volume overload will happen, urine osmolality will be decreasing, of course, because urine cannot absorb anything. Okay, free water loss will be happening. Urine sodium will be increased, creatinine level will be increased, BUN will be increased. If the patient survives this maintenance phase, then they will enter into the recovery phase where the PCD cells regenerate. However, the GFR is increased because the tubular function is not restored right now. Okay, so a transient polyuria and salt wasting will happen. For the treatment in the maintenance phase, you need to give the patient calcium, sodium. Okay, in the recovery phase, you need to maintain the calcium, sodium, potassium, magnesium of the patient. Okay, and you also need to maintain a proper hydration in the recovery phase, because the patient becomes dehydrated because of this polyuria. Otherwise, the patient will die. Okay.
Is it reversible damage?
Yeah. Ask it again.
Is it reversible condition?
Yeah, of course, it is a reversible damage. That's why you are having a recovery phase. You have the stem cells in the kidney, right?
Yes.
So the complete regeneration will occur after some time.
Okay, and the function will restore totally?
Yeah, functions will restore after some time, of course. Within a month, within 2 months, the functions will be restored completely. Okay.
Yes.
Okay, thank you.
Now you have a diffuse cortical necrosis. As the name suggests, in this case, you're going to have a necrosis of the cortex of the kidney. Okay, and as a result, a generalized this infarction of both the kidneys in the cortex will happen. Okay, it could be due to a combination of a vasospasm as well as the DIC. So having a history of DIC, this DIC is important. Having a history of vasospasm is also important. And please note, because a cortex is now become dysfunctionable, you have absolute anuria in this case. It is bilateral, it is not unilateral, right? So it will be absolute anuria in the patient. He won't have any urine output at all within 24 hours. If they have a very slight urine output in 24 hours, think about the ATN. If they have no urine output at all, think about the diffuse cortical necrosis. Patient also have a history like the abruptoplacenta, it could be a pregnant female, septic shock, because all of them can cause the DIC. So anything that can cause the DIC can cause the acute cortical necrosis or a diffuse cortical necrosis. Okay,
Okay, thank you.
so that's about it. Now you have the papillary necrosis. Okay, and you know about the renal papillae, the pyramids and then papillae, right?
Yeah.
These are these triangular-like of lesions, these finger-like lesions, the regions they are, right? So in this case, as the name suggests, you'll be having a necrosis of the papillas of the kidney, and as a result, patient will have a gross hematuria, a gross proteinuria. Okay, it can be because of a recent infection. Okay, so the patient will be having a sterile pyuria. So hematuria, proteinuria, and a sterile pyuria without any eosinophilia. See, you can have a eosinophilia WBC in case of acute interstitial nephritis also. You can have a hematuria in that, you can have a proteinuria in that. So symptoms are very much similar, but if you do not have any cast, if you do not have eosinophils in the urine, okay, then you cannot diagnose the acute interstitial nephritis. In that case, you need to give the patient diagnosis of renal papillary necrosis. Okay.
So here, hematuria without cast.
Yeah, hematuria without cast, because this pathology lie after the tubules, not within the tubules. Okay, so no cast.
Could you please say again, renal papilla where exactly?
See, okay, let me open this anatomy figure for you. Okay, so see, this is your kidney. It has an outer portion that is a cortex, inner portion that is a medulla. In the medulla, you'll be having a medullary pyramids. These are all the medullary pyramids. The apex part of these pyramids are the papillas. Okay. The
Okay.
papillas will open into the calyces. These are the calyces. All these calyces will open into a space, and that is the pelvis. And this finally pelvis will open into the ureter. Okay.
Ureter. Okay.
So
Thank
the
you very
tubules,
much.
all of these collecting ducts will empty into the renal papilla, and finally the renal papilla will enter into the calyces.
Okay.
Okay, so now see, you're having a necrosis of that part, this apex part. So that lies after these tubules. So you won't have any kind of a cast. Okay, so
Yeah,
symptoms will be the
yes.
hematuria will be there, proteinuria will be there, fever will be there because it is a necrosis thing. Fever, hematuria, proteinuria, similar to that of acute interstitial nephritis, but you won't have any cast and you won't have any eosinophilia on the urine analysis. Okay.
Okay. Okay.
These two things will differentiate between the acute interstitial nephritis and the renal papillary necrosis.
Okay. Thank you very
Now
much.
let's go back to the first aid again and see. The patient must be having any of these risk factors. One is the sickle cell disease. Second is the acute pyelonephritis. Third is any analgesic use, the NSAIDs. And fourth are the diabetes mellitus. So any of this history does, you can remember them by the SAD Papa. Okay, sickle cell anemia, acute acute pyelonephritis, analgesics, and diabetes mellitus. They all can have the renal papillary necrosis also. Okay, in this case, patient will be having a very gross hematuria, visible hematuria will be there, not this microscopic hematuria, but it will be a very visible gross hematuria. Proteinuria will be there without any eosinophilia, without any rash. Okay. Now let's discuss why you are having this injury with the NSAID. Let's discuss the injury, these NSAIDs and how these NSAIDs can cause that damage to my kidney. Okay, so far you know that these NSAIDs can cause two type of a damage. Either it could be a acute interstitial nephritis or it could be a renal papillary necrosis, right?
Yeah.
This acute interstitial nephritis is because of an autoimmune thing, because of a hypersensitivity thing, right? But this renal papillary necrosis is because of a toxic effect of these NSAIDs. When the patient is on an acute NSAID therapy, they can have an acute interstitial nephritis. That means, within a month after initiating the NSAIDs, patient can have a renal this acute interstitial nephritis. But after a chronic use of these NSAIDs continuously for years or for 2 years, okay, because of any bone pain or any accident or any kind of a trauma because of that, okay, the patient can have a renal papillary necrosis. Now, what happens is, that the cortex portion is isotonic, and as you go from cortex to medulla, that portion become very hypertonic, right?
Right.
Osmolality increases going from cortex to medulla. And these papillary parts, the renal papillae, they are highly hypertonic. They have very high osmolarity, okay?
Yeah.
And these NSAIDs also, they all accumulate along this osmolarity gradient. Okay, so the maximum concentration of these NSAIDs are found in the renal papillae. Okay, and that's why they only causes the damage in the renal papillae, because they accumulate there. Okay.
Okay.
Now, whenever you have the papillary necrosis, because of this accumulation, okay, we know that the NSAIDs can inhibit the electron transport system.
Yeah.
Aspirin, remember?
Right.
Yes.
So the aspirin can inhibit the electron transport system, and that will put the cell on an oxidative stress. Okay, and that oxidative stress can cause the papillary necrosis. Now, because of this papillary necrosis, patient first have an intrinsic renal failure, a BUN creatinine less than 15. Patient will be having a WBC without any cast, of course, that you already know. Hematuria will be there, gross or microscopic both. Okay. Now, because there's a necrosis there, after this necrosis, you will also have a calcification there, the dystrophic calcification because of necrosis.
Yes.
So a chronic patient on NSAIDs, a patient on a chronic NSAID therapy, they will have a calcification on the papillas instead of the necrosis. Okay, so whenever you encounter a patient having a calcifications on the renal papillae, okay, having a history of NSAIDs, you always think about the papillary necrosis or a chronic interstitial nephritis, not the acute, but a chronic interstitial nephritis. Okay.
Okay.
So a patient who is having an acute interstitial nephritis, he will be having an inflammation in the interstitium of the kidney. A patient who is having a chronic interstitial nephritis, he will be having a calcifications on the papillas, having a necrosis of the papillas.
Right.
Okay. So what other things you will see? Signs and symptoms of the chronic inflammation. These are the fibrosis, renal atrophy, tubular atrophy, patchy interstitial inflammation will be seen. On the grossly, because of this atrophy, kidney will appear very shrunken. Papillary calcifications will also seen. Okay. So whenever you encounter a patient having a history of chronic NSAID use for more than 6 months, okay, think about the patient can have a chronic interstitial nephritis. In that case, calcifications on the renal papillae will see. Okay, intrinsic renal failure will be see. All the signs and symptoms of this intrinsic renal failure will be there. Okay, WBCs without cast will be there. Hematuria, calcifications, fibrosis, atrophy. All of these things will be seen in the renal papillary necrosis. Okay.
Yeah.
Okay.
Similar thing goes for the sickle cell diseases. Whenever you have a high osmolarity, a high oxidative damage, I told you that this medulla is a hypoxic area, right?
Yes.
So and this papilla are the most central portion of this medulla, so they become very most hypoxic areas. In that case, a patient having a sickle cell disease or a trait, even a trait can do that. Okay, the sickling of the cells will happen in the papillas of this kidney, and as a result, patient can have a renal papillary necrosis there because of a blockage of the vessels. Okay. So that's about the renal papillary necrosis. Any doubt, please ask.
Another question. Can you get pre-renal failure before acute tubular necrosis? And if so, how do I tell if I have
Can I get a?
Can you get pre-renal azotemia at the same time as you get acute tubular necrosis?
If you're having an acute tubular necrosis, and how can you have a penile azotemia?
Sorry, my question makes no sense.
Yeah. The
Oh,
question is
post. Yeah, never mind.
see, at the initial time, you can have a penile azotemia. Then this penile azotemia will convert it into the intrinsic renal failure if the condition become very much severe. But one at a time only, right? Not the both simultaneously.
Okay. Okay. Thanks.
So that would be everything on this page. If any doubt, please ask.
No, thank you.
No, thank you.
Now comes the consequences of the renal failure. We have already discussed every one of them. I told you have the electrolyte balance thing in the kidney. You have this osmolarity balance thing in the kidney. Water balance in the kidney is also there. Acid-base balance is also there. Other functions like the vitamin D, like the erythropoietin, these are the minor functions of the kidney. Whenever you have a kidney failure, first thing you will have is the metabolic acidosis, high anion gap. It must be. Second thing is a dyslipidemia. Okay, because your liver try to compensate for all this protein loss and other things. You will have a high triglyceride level. Okay, your kidney cannot excrete all these things, right? So you'll be having a high triglycerides, high potassium, because the function of kidney is to excrete this potassium and to reabsorb the sodium. So hyponatremia will be there, hypokalemia will be there, hypomagnesemia will be there, but a hyperkalemia will be there. Okay, uremia will occur because of excessive deposition of all these acids which cannot be excreted now because of this renal failure. Because of this uremia, patient will have a nausea, anorexia, pericarditis. If you guys go back to the CVS, pericarditis can also happen. Okay, and tachycardic tamponade can also happen because of this uremia. Asterexis happen because of this hyperammonia thing. Okay, BUN levels are getting raised. Hyperammonia is happening. Patient will have asterexis also. Encephalopathy because of this thing, because of the hyperammonia can also happen. Because of this uremia, platelet dysfunction will also happen. In that case, the bleeding time will increase. Platelet count will be normal. Clotting time will absolutely normal. PT and PTT. It's just a bleeding time with a normal platelet count. Okay.
Yes.
So whenever you encounter a patient having a history of chronic kidney disease on the dialysis, and now he's having a bleeding from different sides, having a high bleeding count and a normal PT-PTT, think about the platelet dysfunction due to the uremia, okay?
Yeah.
As soon as you perform the dialysis, okay, all these acids and this urea will be excreted from the kidney, and as a result, you will be having a normal platelet function then. So for the platelet dysfunction due to uremia, the dialysis is the important thing you can do, okay?
Why the platelet dysfunction? Sorry, one more time.
Because of uremia, because of all these acids in your body, extra acids, they're interfering with the platelet function, okay?
Okay, thank you.
Now, because of this loss of GFR, one thing. Second thing, and you will be having an activation of RAS also. Because of this loss of GFR, the function of this RAS is to maintain the GFR, right?
Yeah.
So you'll be having a retention of the sodium and water, and that happens chronically. In the acute kidney injury, you will be losing all these electrolytes. In the chronic kidney injury, okay, you will be having a retention of this sodium and water.
Yeah.
Okay, so a retention of sodium and water because of loss of GFR will happen, and that can lead to a increase on the stress on your heart. That can lead to a volume overload. Heart failure will happen, pulmonary edema will happen, hypertension will happen, ascites will happen, peripheral edema will happen because of that, right?
Yes.
Growth retardation, development and delay because of this uremia thing again. Because now this EPO cannot be released, patient will have a low RBCs, anemia will happen. Okay, and one important thing, which is a renal osteodystrophy, will also happen. In the renal osteodystrophy, we have discussed that already. You will be having the activation of fibroblast growth factor 3, right? 23, not the 3, 23, right? And this fibroblastic factor 23 will cause the inhibition of 1-alpha hydroxylase in order to maintain the phosphate levels, right?
Yes.
Remembering?
Yeah.
So in that case, you'll be having a low level of vitamin D. And because your vitamin D is not there, you'll be having a low level of calcium now. But eventually the phosphate level will rise in your body. So hyperphosphatemia and hypocalcemia will be there. High level of pathogenic hormone will happen, and that will cause a resorption of the bone. You will be having a bone resorption, osteoporosis. Bone resorption occurs in the periphery first, that means in the cortex, or you can see the subperiosteal bone resorption will occur, and that leads to the renal osteodystrophy. Okay, all of the phosphate will bind to the free calcium, again causing a hypocalcemia, right? This complex now, the calcium phosphate deposit on different tissues like the arteries, and that will cause the arteriosclerosis. Okay, the Mockenberg sclerosis, you guys remember?
Yeah.
That
Yes.
happens because of it, because of this excessive calcium and phosphate deposition on the arteries. It is not clinically significant. It is always asymptomatic, silent thing. But when you do the CT or MRI of the patient, you can see the enhancement of the aorta or different arteries because of this calcium deposition, right?
Yeah.
Yes.
So step 1 can ask you why this enhancement is seen on these capillaries, on these arteries. So answer would be the deposition of the calcium phosphate because of this kidney failure could be. Okay.
Yes.
So what findings you will see? Low level of calcium, high level of phosphate, low level of vitamin D3, high level of PTH, okay, and calcium phosphate thing. Osteitis fibrosa cystica you will see, right? Subperiosteal thinning of the bones.
Yeah.
Now you can have two forms of renal failure. One is the acute, of course, and second is a chronic. Acute causes we have discussed already. All the causes of acute this intrinsic renal failures, like the acute interstitial nephritis, acute tubular necrosis, diffuse cortical necrosis, okay, renal papillary necrosis, they all are the acute causes of the renal failure. Then you can also have the chronic renal failure. Okay, the major causes are the hypertension and the diabetes mellitus, or any congenital anomaly, of course. But the major one are the hypertension and the diabetes mellitus. Okay.
Okay. Yes.
Yeah.
So yeah, that would be about the consequences of the renal failure. Any doubt, please ask.
No, thank you.
No, thank you.
So, this part we have discussed already, the natural history of the patient with the diabetes. Okay. And contrast-induced nephropathy, whenever you encounter a patient who's undergoing a CT or MRI with a contrast use, or a patient with a percutaneous catheterization, in that you also need to visualize the artery, so you give the patient a contrast, right? With the contrast, you can have a contrast injury, and that happens within 24 to 48 hours after the use of the contrast, and patients rarely have the oliguria. He will have a very little urine output within 24 hours, and that's how you know patient is having a acute tubular necrosis. Vital signs absolutely normal, no hematuria will be seen. It just oliguria will be there, right?
Yes.
Yeah.
And now you have the renal cyst disorders. Okay. And for that, you have this autosomal recessive polycystic kidney disease, autosomal dominant polycystic kidney disease. Okay. Two types. Just give me a second. Okay, so for the autosomal dominant polycystic kidney disease, please note this condition always present itself in the adults. Although the cysts are present in the infants also, but the cysts are very small that they cannot be visualized. As the patient grows, as he become adult, the size of the cysts are also increases. And when they attain a size, okay, which involves more than, I think more than 60-70% of the parenchyma of your kidney, in that case, you will be having a symptoms of the kidney failure. And that's when the patient will present you. Okay, so please note the cyst present from the birth also, but they only become visible in the adult life. Okay.
Yes.
No.
No.
Yes.
Yeah. In case of my autosomal recessive polycystic kidney disease, the cysts are present at the time of birth, and they have this enough size that they can be visualized at a very early stage in a child also. So this condition will present itself in the childhood, and this condition will present itself in the adulthood, although both the conditions are present at the time of birth. So if the step one asks you that about a patient who is having some kind of a kidney defect, and if they ask you that in order to get a renal failure due to this defect in the adulthood, what kind of a defect it could be, autosomal dominant or autosomal recessive? So answer would be the autosomal dominant. The defect is present, but the defect will only present itself in the adulthood. Okay.
Okay.
Now these cysts are nothing but just the normal tissue. Okay, this normal tissue is becoming cystic like, and as a result it will be filled with some kind of a fluid. Okay, this cyst will be occupying the normal renal parenchyma. Okay, the place where your nephron should be. Okay, and this performing normal functions. Instead of these nephrons, the cysts are present there, and as a result, because they're occupying the normal renal parenchyma, okay, it will be interfering with the normal kidney function, and as a result you will be having a renal failure because of that. In case of my autosomal dominant polycystic kidney disease, you'll be having a numerous cyst in the cortex and medulla. So it will be a diffuse condition. It will be a bilateral condition, so affecting both of my kidneys. Okay, it will be destroying the parenchyma of the kidney, and when the enough parenchyma is destroyed, okay, the remaining parenchyma cannot take over the functions now. Okay, they cannot perform their function normally. In that case, the patient will present with a renal failure. So patient will be having a progressive renal failure. Okay, flank pain will be there because of this mass in the kidney, because of course they are a mass, so it will causing a flank pain. Hematuria will be happen because of kidney dysfunction. Hypertension will happen. Fluid overload, edema will happen. It will predispose the patient developing the urinary infections also. Mutations in the PKD1 gene, polycystic kidney disease 1. Okay, you don't need to remember the chromosome. PKD2 can also cause it. Okay. Complications, patient will be having a chronic kidney disease, of course, renal failure will happen. Hypertension because of the increase in renin production because kidneys become dysfunctionable, right? Patient can also have the Barry aneurysms, important thing. And does anyone remember if the aneurysms got ruptured, where does the blood will accumulate in the brain because of this Barry aneurysms?
Subarachnoid.
In the subarachnoid space. Patient also have the mitral valve collapse. Okay, this benign hepatic cysts can also be present. The verticulosis can also be present in the patient. And just like any other treatment of the kidney, you will always give the patient renoprotective drugs, and these are the ACE and the ARBs. Okay, so yeah, that's about my autosomal dominant polycystic kidney disease. Okay, these all cysts are damaging your normal renal parenchyma, causing a kidney failure. Any doubt?
No, thank you.
Then you have the autosomal recessive polycystic kidney disease. And please note the cysts are formed from the collecting ducts. The collecting ducts in the kidney, they form a cyst-like thing. It will occupy the normal this parenchyma, causing a kidney damage, and ultimately patient will be having a renal failure. It will present itself in a very early stage in the infancy already. It is also associated with the congenital hepatic fibrosis. So patient will always have a history of portal hypertension and then the kidney failure. They will have a very systemic hypertension at a very neonatal stage only, very early stage. Progressive renal insufficiency will happen as the patient grows. Portal hypertension from the hepatic fibrosis. So these are the findings you will see in the autosomal recessive polycystic kidney disease. It is diagnosed in the infancy. You do the MRI or CT of the patient, you find these kind of a cyst-like things in the kidney bilaterally. It must be bilateral, okay? So a bilateral cyst will be present, nodular appearance, you will see on the CT MRI, on the gross finding, these kind of a cyst will see. You can also perform, the ultrasound on the patient. Cyst can be visible there. Okay. So ultrasound, you will perform. CT, you will found the bilaterally enlarged kidney with multiple cysts or abnormally shaped kidney on the CT MRI will be seen. Portal hypertension, systemic hypertension, kidney failure, okay, edema, okay, fluid overload, all these things will be found in the infant of this autosomal recessive kidney disease. Okay.
Yes.
That will impair the kidney function, right?
It will impair the kidney function, of course, because the normal parenchyma is now getting damaged.
Okay.
So
So
number
they
of,
need transplant.
yeah, of course, our treatment is a transplant,
Thank you.
because all these nephrons are getting died. If the nephrons are not there, so nothing will refiltrate out things, the hyperfiltration, the reabsorption will all loss. You'll be having a loss of fluid and retention because of this loss of GFR and other things. So ultimately losing the nephrons means losing the kidney, right?
Yes.
Yes.
Now you have the autosomal dominant tubointerstitial kidney disease. Okay, in this case, you'll be having a medullary cysts only, not the cortex, but only cysts are found in the medulla part, not in the cortex part. So if you encounter a cyst both in the cortex medulla, think about ADPKD. If you're having a cyst only in the medulla, no cortex, think about the autosomal dominant tubointerstitial kidney disease. You'll be having a fibrosis in the kidney, tubointerstitial fibrosis will be there. You cannot concentrate the urine. So the specific gravity of the urine will be very low. Osmolarity of the kidney, of this urine will be very low. Medullary cyst, okay, they are not usually visualized. So, when you do the this MRI or CT of the patient, you only found the shrunken kidney. Bilaterally small shrunken kidney will be seen, no cyst will be identified. Okay, you do the gross finding of the patient on the gross examination, you will visualize this cyst there. Okay, so normally cysts are not seen on the CT MRI. What you will find only the shrunken kidney bilaterally. Once you remove the kidneys and you picture them, you will find that the cysts are present in the medulla part. Okay.
Yes.
Okay.
And because it is autosomal dominant, so multiple members of the family will have the history of chronic kidney disease. So if a patient is having a family history in which multiple family members have a renal failure history, you can think about the autosomal dominant tubointerstitial disease. When you do the CT MRI of the patient, you found the patient is having a bilaterally shrunken kidney. And because it is a family condition, it means it is autosomal dominant tubointerstitial kidney disease. They will ask you about the specific gravity. It will be very low because the patient cannot concentrate the urine. You'll be having a tubointerstitial fibrosis also. And that is a biopsy of the patient you will see. Okay.
Yes.
Yes.
Now you have the simple cyst and the complex cyst. Simple cysts are nothing but just filled with the ultrafiltrate, the GFR. Okay. And the complex cysts are filled with some solid components. Could be a cells, could be anything. For example, if you find the cystic appearances on the kidney, which are solid, okay, the nodular appearances on the kidney, you can think about the renal cell carcinoma also, right? So this thing can also increases the risk of renal cell carcinoma, especially the complex cysts. Okay, and the simple cyst can also be found in normal patient. 1 or 2 cysts are generally present, and this is absolutely normal. When many cysts are present, which are occupying a massive region of your kidney, a massive parenchyma of your kidney, then it becomes very much problematic. That exactly happen in these 3 disorders. Okay.
Yes.
So that's about these cysts. So a patient having and along with that also you need to also note the fact that in case of, because the kidney cannot be excreting my things, you'll be having a retention of the uric acid also. And because of this retention of uric acid, patient will also have the hyperuricemia. So a hypouricosuric hyperuricemia will be seen in the patient. Okay, the patient cannot excrete the uric acid in the kidneys. So low level of uric acid in the urine, a high level of uric acid in the serum, that you will find on these patients. A patient having a multiple family history, having a hyperuricemia, multiple family members having a gout, having a kidney failure at a very early stage, generally you have the kidney failure in a very old age after 50 or 60 years. In this scenario, patient will be having a kidney failure in 30s or 40s only. So multiple family members having a kidney failure on the age of 30s and 40s, multiple family members having a history of gout. Think about the autosomal dominant tubo-interstitial disease, okay?
Yes.
Then you have the renovascular disease in which you're having a stenosis in the renal artery, and as a result, they cannot perfuse your kidney, and as a result, you'll be having a ischemia and necrosis of the kidney. Whenever the renal perfusion decreases, you'll be having an activation of RAS because of baroreceptors found on the afferent arterioles, remember?
Yes.
So because of RAS, you'll be having a hypertension also. If it is bilateral, then you'll be having, the normal findings in both the kidneys. Both kidneys will have similar findings. Okay, atrophy will be there, fibrosis will be there. Okay, RAS will be there from both the kidneys. But if this condition is unilateral, then on one side, you're having a hypoperfusion and that causes the atrophy of the affected kidney, fibrosis of the affected kidney. RAS will be released from the affected kidney, causing a hypertension that increases the blood flow in the normal kidney. Is that okay?
Yes.
Will
The perfusion
increase
in the
in
normal, yeah,
the blood flow will increase in the other kidney.
yeah, the blood flow will be increased in the other kidney because of this high blood pressure, right?
High blood pressure should increase the blood flow, right?
Yeah.
Okay.
Now, because of this high blood pressure and increase in the blood flow to that normal kidney, okay, opposite thing gonna happen in the normal kidney. Because of this high blood pressure, you will be having a arteriolosclerosis. Is that okay? Arteriolosclerosis, high line type or a hyperplastic type, depending upon how much BP patient is having.
Yes.
So that causes the decrease in the lumen of the normal kidney. First thing. Second thing, you will be having the inhibition of RAS in the normal kidney. Okay. And because the RAS is inhibited in the normal kidney, you will be having a sodium loss, bicarbonate loss from the normal kidney, right? But the increase in the sodium, increase in the bicarbonate in the affected kidney. Yes.
Which part will dominate the effect on the circulation? The defective
It
kidney or
depends.
stenosis one, or
It depends upon the severity. You cannot say which part is dominating. You will look for the patient, look for their sodium levels. If it is decreased, that means it will be the normal part which is dominating. If it is increased, that means it is the affected part which is dominating. So you cannot say theoretically which part is dominating. It just in one part you're having a loss of sodium, in other part you're having an absorption of the sodium.
Loss of sodium on the normal one.
Yeah, because the RAS is inhibited in the normal one because of high blood pressure, right?
Yes.
You need the RAS to maintain the blood pressure in the body, right? To maintain the blood flow to the kidney. Because the blood flow is already very much increased in the normal kidney because of the stenosis of the other kidney, you're having
Yes.
an inhibition of the RAS and the
Yes.
activation of RAS on the affected kidney.
Yes.
You do the CT MRI of the patient abdomen, what you will find is the atrophy of the affected kidney, right?
Yes.
You do the biopsy of the patient of the affected part, what you will find is the fibrosis and all this collection of the glomeruli, that you will find on the affected kidney. The crowding of the glomeruli will be seen, fibrosis will be seen, atrophy of the cortex, medulla, parenchymal ischemia, that you will find on the biopsy of the patient of the affected kidney. Okay.
Yes.
Now comes the causes. These are the atherosclerosis, of course. And whenever you have the atherosclerosis, it will always affect the proximal 1/3 of the renal artery. The location is very important. It is always proximal 1/3. Step 1 will describe your scenario, and they will tell you on the angiography, the patient is found to be having a stenosis in the proximal 1/3. And that means they're talking about the atherosclerosis. If they tell you that the stenosis is in the distal 2/3, that means they're talking about the fibromuscular dysplasia. Okay, and this condition will be found in the middle-aged females. Okay, you're having alternative areas of stenosis and alternative areas of the aneurysms in the kidney. Okay,
Yes.
so for the distal two-third blockage, fibromuscular dysplasia, FMD. For the proximal, it will be atherosclerosis. If the patient is having atherosclerosis, then the patient will be having a high turbulent flow there, right? Turbulent flow.
Yes, 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 yes. Brui,
Because of
yes.
this, yeah, because of this flow, patient will also have the bruits on the stethoscope. When you hear,
Yes.
okay, you will place the stethoscope on this flank region on the abdomen. What you will find are the bruits, and that's how you know either the patient is having an aneurysm or the patient is having a stenosis there, right?
Yeah.
So a patient having a shrunken kidney, cortical thinning, tubular atrophy, interstitial fibrosis, a small crowded glomeruli, think about the ischemic damage to the kidney. Okay, patient will having a this refractory hypertension. If you give the patient normal drugs, it cannot overcome this hypertension. It will be refractory to other all drugs. So then only you will think about this renal vascular disease. When you give the patient every drug, but no drug is functionable, no drug is affecting. Okay, so then you will think about this renal vascular disease. If the bilateral stenosis happen, then you will have a high level of creatinine. If unilateral stenosis happen, you won't have an elevated creatinine. Okay,
Okay.
epigastric pain, flank pain will be seen, bruits will be also seen. Okay, asymmetric renal sizes will be seen, and these are the most common cause of secondary hypertension in the adults. Okay, treatment, of course, you can give the patient ACE and ARBs. NSAIDs must be avoided in the patient because NSAIDs will further decrease the renal perfusion, can cause the intrinsic renal failure also, right?
Yes.
Okay, so in the affected kidney, you're having a pre-renal azotemia. In the normal kidney, it is absolutely normal. Okay, everything. Okay, so in the affected kidney, pre-renal azotemia. In the normal kidney, everything is overloading now,
Yes.
right? So that's
Yes.
about my renovascular disease. Any doubt, please ask.
No, thank you.
So that's about the renal infarction. We have discussed all the symptoms already. Causes includes the atrial fibrillation. It can be happen post MI. It could be happen in the endocarditis. It can happen after the prosthetic valves, because these valves can form the embolisms in it, right? So all of these are the risk factors. Patient will be having a history of palpitation or a chest pain or a history of fever, murmurs, endocarditis, valves could be that. Features, flank pain will be there. Flank pain will be there. Hematuria without any cast, vomiting, low-grade fever will be there. Hypertension will be there. High level of LDH will be there. Leukocytosis will be there. Okay. The serum creatinine often normal if it is unilateral. If it is bilateral, then only you can have a rise in the serum creatinine. Okay. And on the cross examination, patient will have a sharply demarcated area of yellow-white infarct. That is a pale infarct. I told you in all of your body you will be having a pale infarct, right? Except some
Yes.
areas where you have a red infarction.
Yes.
So a wedge-shaped area of pale infarct, a highly demarcated area will be seen on the gross examination of the patient. Then you have the fibromuscular dysplasia. And as a name suggests, you're having a dysplasia in the muscle layer along with the fibrosis. Okay, so it will cause this arterial stenosis. Tortuosity will happen, aneurysms will be formed, and dissection can also happen. It is generally seen in the females having a age less than 55. So it would be always a reproductive age female, a young patient. Okay, you'll be having alternate areas of aneurysms and alternate areas of stenosis. That gives the patient a artery, a string of a bead appearance on the CT or MRI of the patient. On the angiography of the patient, you will see the string of bead appearance. Okay, you'll be having a fibromuscular webs that causes the stenosis with alternating areas of aneurysmal dilations. Okay, loss of internal elastic lamina, and because the elasticity is now lost, so these blood vessels cannot attain their normal shape. So that's why they will become very dilated. Because of this fibrous dysplasia, you will be having a fibrosis in the vessels, and that's why the fibromuscular webs are formed. So if I draw this, if this is your normal vessel, okay, then in case of my fibromuscular dysplasia, alternate areas will become stenotic because of this fibrotic webs, and other areas will become dilated. Then stenosis, then dilation, then stenosis, then dilation. That kind of a thing will be seen on the angiography of the patient, right? So in these areas, you'll be having a fibrosis, and that's why the area become very stenotic. In these areas, because of loss of internal elastic lamina, these areas become dilated because of high compliance, okay?
Yes.
And please note, other than your kidney, these fibromuscular dysplasia can also affect the brain vessels. So if the step one describe you a patient having, some alternating areas of aneurysms and strictures in the brain, okay, and having a history of hypertension, a female, they will ask you why this patient is having a hypertension. So it would be because of a fibromuscular dysplasia affecting the renal vessels. Is that okay?
Yes.
That's about it.
Yeah.
Any doubt, please ask.
No, thank you.
Then you have the renal cell carcinoma. Okay, it is a cancer that is originating from your renal cells. Okay, and it originates most commonly from the proximal convoluted tubule. Okay, these are all the polygonal clear cells. As you can see, they are all the clear cells. Why clear? Because these cells are filled with the lipid. Okay, so these all cells are filled with the lipid and the carbohydrate that cannot be stained, and that's why these cells appear very much clear. They have a very clear cytoplasm. Just the nucleus of these cells and the boundaries of cells are visible. And because these cells are filled with the lipid, okay, that means this condition must be associated with the increased lipid content in your body, right?
Yes.
And that's why the incidence is always increased in the smoking patients and the obese patient. So patient must be having a history of obesity or the smoking for in order to have a RCC. Okay, these cells will invade the renal vein and obstruct this inferior vena cava. Okay, ultimately it could also obstruct the renal vein, and if they obstruct the renal vein, you can have a varicocele also. Remember,
Yes.
left renal vein.
Really,
Okay, and
yes.
from the inferior vena cava, patient can have a hematogenous spread. And please note, all this spread goes to the lungs and the bone, and that's why the most common presenting complaint of the patient with RCC is a the difficulty in breathing and a bone pain. So a patient having difficulty in the breathing and bone pain, okay, then you could be think about it could be a primary cancer of the bone or lung, okay, or it could be a metastatic, right? Now, when you took further history of the patient can have a history of smoking. That means he could be having a lung cancer primarily, or could be a RCC primarily, right? Then you take a further history, you will find the patient is having again systemic signs and symptoms of inflammation or disease, like the fever will be there, fatigue will be there, weight loss will be there. Other than that, patient can also have a flank pain. And when you see the flank pain in the patient along with this lung and bone symptoms, you will immediately know that the patient is having a renal cell carcinoma. You do the CT MRI of the patient abdomen, what you will find, these kind of a mass on the kidney. Okay, this kind of a irregular mass unilaterally will be seen, and that's how you know patient is having a renal cell carcinoma. Okay, so the manifestations are the hematuria, palpable mass, polycythemia, because this tumor releases the erythropoietin, flank pain, fever, weight loss. But generally, you won't see any of the symptoms except the fever, weight loss, flank pain, polycythemia, and hypertension. These are the most common presenting complaints of a patient with RCC. Hematuria, palpable mass are generally not seen. Okay, so patient with fever, weight loss, fatigue, flank pain, okay, CT showing a renal mass, hypertension, polycythemia, think about the renal cell carcinoma. Okay.
Okay.
Now, if the tumor cells metastasizing to the inferior vena cava, if they obstruct the inferior vena cava, patient will have a symmetric, or you can say a bilateral lower pitting edema, tortuous abdominal veins will also be seen. Varicocele, of course, you will get also bilaterally now. Okay, so these things happen whenever you have an inferior vena cava obstruction. It is most commonly seen in the males having age between 50 to 70 years with a history of smoking or a history of obesity or some kind of a chemical exposure, like working in a chemical factory can do that. It will always associated with the paraneoplastic syndrome. This tumor can release the parathormone like peptides, so you'll be having a bone resorption with hypercalcemia. Patient can have an ectopic EPO, so hematocrit will be increased. ACTH could be released, right? What other tumor can release the ACTH?
Small cell.
Yeah, small cell lung cancer. And what disease you can get because of this ACTH releasing tumor?
Cushing
What?
Cushing syndrome.
Not the Cushing syndrome, but the Cushing disease,
Cushing
right?
disease.
Two different things. Okay.
Yeah.
Then the renin will also be increased. They can also secrete the renin, so that will cause the hypertension. So hypertension, high hematocrit. Okay, viscosity symptoms will be there, of course, hyperviscosity symptoms, flank pain, bring of vision, fever, weight loss. These are the presenting complaints of the patient with the RCC. The classical triad will never see. Okay, the hematuria, palpable mass, flank pain, they are generally not seen in the patient. Just the fever, weight loss. Okay, and the patient will be having a this lung symptoms like the shortness of breath will be there. Bone pain will be there. You do the biopsy of the lung, you do the biopsy of the brain. What this bone, what you will find is the clear cells, and that's how you know the tumor must be metastasized in these locations from the kidney. Okay.
Yes.
Yeah. So the biopsy of the patient is very important. The clear lipid-filled cells. Then you have a renal oncocytoma, which is a tumor from the collecting duct. It is a very, very demarcated, you can say, tumor. Okay, it is a benign tumor, of course. Okay, and the sign, see, in case of my RCC, on the gross examination of the tumor, you will see the areas of hemorrhage and the necrosis, showing that the tumor is having a very high malignant potential. Once you see the renal oncocytoma, because it is a benign tumor, okay, you won't see any necrosis, you won't see any hemorrhage on this tumor. It will be a diffuse, homogeneous, sharply demarcated mass. As you can see, the borders are very sharply demarcated, right?
Yes.
And unlike my RCC, you cannot have any kind of this necrosis or this hemorrhagic regions, right?
Yes.
So it will be a tumor which is sharply demarcated. Okay, in the center, it will be having a scar. Okay, and surrounding that scar, you will be having the tumor. Okay. On the examination, you will be having the large eosinophilic cells on the biopsy of the patient. You will be having a large eosinophilic cells because of the cells are rich in the mitochondria. They do not have any perinuclear clearing unless, unlike the RCC. So no clear cells will be seen. Paleness hematuria, flank pain, and this paleness hematuria is important. Whenever you have a tumor of your urinary tract, that means a RCC, renal oncocytoma, okay, or any tumor in the urinary bladder, they always present you with the painless hematuria. That is an important thing. So whenever you encounter a patient with a painless hematuria, the first thing that you must diagnose is the cancer of the patient. Okay, cancer of any part of the urinary tract, unless you can prove other thing. So a
Yes.
patient with hematuria, the first thing you will always know is the tumor. You will run all the tests for the tumor. Unless you get all the tests negative, you won't diagnose any other thing. Okay. So painless hematuria or gross hematuria should be considered a sign of a urinary tract cancer unless proven otherwise. This is a very important thing. Flank pain, other mass will also present. So a brown homogeneous tumor with a central stellate scar without any necrosis, without any hemorrhage, okay, with a demarcated capsule. Always think about the renal oncocytoma. Any doubt, please ask.
No, thank you.
So that would be difference between the RCC and the renal oncocytoma. Necrosis, hemorrhage, clear cells, RCC. No necrosis, no hemorrhage, homogeneous, demarcated mass with eosinophilic cells, renal oncocytoma. Painless hematuria could be present in both. Flank pain could be present in both. Fever, weight loss, fatigue could be present in both. Hematuria will be present in both. So biopsy and the cross examination will help you identify the cause. Okay.
Yes.
So let's take a short break and then discuss the nephroblastoma and other tumors and then discuss the pharmacology. Okay.
Yes. Thank you.
Okay, so the nephroblastoma, which is also known as the Wilms tumor, if you guys go back to the embryology lecture, we have discussed that the metanephric mesenchyme is what forms the Wilms tumor, remember?
Yes.
So this Wilms tumor is nothing but the tumor of this metanephric mesenchyme. So it will contain all the embryological glomerular structures. That means from the glomeruli up to the DCT. Okay, all these structures will be present in the nephroblastoma. Okay, it will present as a large palpable unilateral flank mass. Okay, please note it must be unilateral. It cannot cross the midline, so it cannot be bilateral. Okay, versus the neuroblastoma. Remember, in the endocrine session we have discussed
Yes.
neuroblastoma. The neuroblastoma, it can cross the midline, so it can become bilateral. But the nephroblastoma is only unilateral. In both the cases, you'll be having this kind of a kidney mass. If this kidney mass is crossing the midline, that means it will be the neuroblastoma. If the kidney mass is remaining on the unilateral side, that means it will be the Wilms tumor. Okay.
Yes.
So along with this large palpable unilateral flank mass, patient will also have a history of hematuria, and patient can also have a hypertension. Versus in case of neuroblastoma, you cannot have the hypertension. You always have a normal BP. Other thing you can look for are the metabolites of epinephrine and non-epinephrine, the HMA, VMA, remember?
Yes.
So these things will help you differentiate between the nephroblastoma and the neuroblastoma. It happens because of a loss of function mutation in the tumor suppressor gene, WT1 or the WT2. Okay, and please note, both the genes must be knocked out in order to get a cancer, right? Remember the nuts and 2-hit hypothesis?
Yes.
So both genes must be knocked out. Now you have multiple syndromes associated with this nephroblastoma. You can have a Vaga syndrome, you can have a Dennis-Strauss syndrome, you can have a Backford-Wiedemann syndrome. So let's discuss the first, the Vaga syndrome or the Vaga complex, in which you have a Wilms tumor, okay, and iridia, in which your iris is absent in the eyes. Some part of iris could be absent, okay, and iridia you call it. Genitourinary malformations will be seen, and mental retardation will be seen. So WAGR is seen in the Vaga complex. It is because of a WT1 deletion. Okay. Then you have the Dennis-Strauss syndrome, in which you have a diffuse mesangial sclerosis. You will having a, sclerosis of the mesangium of the of this kidney. Okay, so diffuse mesangial sclerosis, thickening of the this mesangium in the glomeruli will be seen. So early onset of nephrotic syndrome will be seen in the infant. So a patient who is age of 2 or 4 years of age, and now he's having this nephrotic syndrome. Think about the nephroblastoma along with this mass. Okay, so a patient of age between 2 to 4 years having a this nephrotic syndrome, proteinuria along with this mass. Think about the Dennis-Strauss syndrome. Dysgenesis of the gonad will also happen, and that can lead to the male pseudohermaphroditism. Okay, and it happens because of a WT1 mutation. Okay, what this thing is we will discuss later in the reproductive section. Okay, so you will have a dysgenesis of the gonads, male pseudohermaphroditism will be seen. Then have the Backford-Wiedemann syndrome, in which you have the organomegaly. All of your organs will become very much enlarged heart, enlarged liver, enlarged kidneys, enlarged tongue. That means a macroglossia will be seen. Okay, and hemihyperplasia will be there because of a WT2 mutation. So the WT1 mutation, the Vaga complex, WT1 mutation, Dennis-Strauss syndrome, and WT2 mutation, Backford-Wiedemann syndrome. For that, you must remember organomegaly, omphalocele. If you look back into the GI section, we have discussed in the embryology part about this omphalocele and the gastroschisis. Remember?
Yes.
And the cause of this ampholycele, I told you that one of the cause is the Wilms tumor,
Yeah.
also the Backfield-Widman syndrome. And the other causes, anyone remember?
Lateral fold closure, honey,
Yeah, of course.
spindle fold.
Like all of these things can cause the lateral fold closure defect, but other associations I'm asking about, not a pathology, but associations. Anyone? The trisomies. Trisomies, 18 and 13, remember?
Yes.
They can cause the ampholycele also. So remember that. So that's about my nephroblastoma, a unilateral kidney mass of primitive these structures of the kidney, of the nephrons, originating from the metanephric mesenchyme. Large palpable unilateral flank mass will be seen, flank pain will be seen, hematuria, hypertension. Different syndromes will be seen, on all because of WT1, WT2 mutations or deletions. That's a nephroblastoma. Age, must remember, 2 to 4 years. Okay. So that's it. Any doubt, please ask.
Thank you.
No. Thank you.
The second one is the urothelial cancer. And the urothelial cancer, of course, happens in the uroepithelium, which is a lining of your urinary bladder and the ureter. This tumor originates from the urinary bladder. Okay. Actually, this tumor can originate from anywhere, in the ureters, in the pelvis, in the calyces, in the urinary bladder, because all of these structures are lined by the uroepithelium, right? The urothelium. Yes.
Yes.
So all this renal calyces, pelvis, ureter, bladder, they can have this urothelial carcinoma. Of course, like any other cancer of this urinary tract, patient will have a painless hematuria without any cast. Whenever you encounter a patient having a painless hematuria, the first thing should be came into your mind is the cancer of the urinary tract. Okay, and you must think it is a cancer unless you prove it otherwise, of course, right?
Okay.
So a painless hematuria without any kidney mass, without any cast, it will be the urothelial cancer. Okay, so the risk factors include smoking, okay, aniline dyes like the this naphthalene, okay, cyclophosphamide. I told you it can cause a hemorrhagic cystitis and the bladder cancer, right?
Yes.
And one more bug, which is the Schistosomia hematobium. Remember
Yes.
the Schistosomia hematobium? It can also cause the cancer of the urothelium. So if the patient is having a history of any traveling, okay, or a patient with the immigrant status, think about the infection with the Schistosomia hematobium that is causing the cancer. Okay, if the patient is a factory worker, it can happen because of a rubber factory, plastic factory, aniline dye, or a textile or a leather industry. They all can cause the urothelial cancer. Smoking, if the patient is having a smoking history, then please note for any of the cancer, the urothelial cancer, okay, this RCC, they have a very strong association with this smoking also. So smoking, aniline dye, okay, occupation hazard, cyclophosphamide, they all can cause the urothelial cancer. Okay, now once you see that the patient will suspect that the patient could be having a urothelial cancer, you will do the cystoscopy. On this cystoscopy, you will find the mucosal mass in the urinary bladder. As you can see, this kind of a mucosal mass will be visible on the cystoscopy. You will take a biopsy of the patient with a cystoscopy. On the biopsy, you will find these kind of a papillary masses. Okay, these kind of a papillary structures will be seen, and that's why it is a papillary kind of tumor. Okay, it has a central fibrovascular core. As you can see, at the center you will be having these blood vessels. The blood is present here, right?
Yes.
And all these fibrotic areas is present. Okay, and surrounding this fibrovascular core, you have these cells, the tumor cells. Okay, dysplastic urothelium will be seen. So these kind of a papillary masses will be seen on the biopsy of the patient. This kind of a mucosal mass is visible on the endoscopy of the patient. Okay, patient will be having a history of painless hematuria. If the patient is having a terminal hematuria, think about the schistosomia. Okay, they always have a terminal hematuria. Okay, and yeah, that's all about the urothelial cancer. And if they ask you how, how can you say whether the patient is having a good prognosis or a bad prognosis? So this could be done with the help of TNM staging. On the TNM staging, you will look for the depth of invasion. Okay. If the cancer is invaded into the muscular layer, the detrusor muscles, that means the patient must be having a very bad prognosis or a very poor prognosis. If the cancer is still limited to the mucosa and submucosa, that means patient is having a very good prognosis. Okay, lymph node involvement is other thing. And does anyone remember what lymph nodes strain the this urinary bladder? Anyone? No? Internal iliac and the external iliac lymph nodes, right?
Yes.
Yeah, so these lymph nodes draining this urinary bladder, and whenever the metastasis happen, it will affect these areas first. These lymph nodes will be affected first. So biopsy from these lymph nodes are also taken. If you find a biopsy positive for these tumor cells, that means patient is having a very poor prognosis. Metastasis is already happened, right? If no involvement of lymph nodes is seen, that means patient is still having a very good prognosis. So prognosis depend upon the TNM staging. Okay. So a papillary or a nodular or a sessile mass will be visible on the endoscopy of the patient or a cystoscopy of the patient. You take the biopsy, you will find these kind of a papillary lesions, right, with a central fibrovascular core. Any doubt on the urothelial cancer, please ask.
No, thank you.
And now you have the squamous cell carcinoma of the bladder. I told you that this calyces, pelvis, ureter, bladder, they are all lined by the urothelium, which is a specialized epithelium. So you always have a urothelial cancer, but you also can have this squamous cell carcinoma. In order to get a squamous cell carcinoma, this urothelial must be converted into the squamous cell first, right? Yes.
Yes.
And what is this term called? Whenever one type of cell convert into other type of cell?
Metaplasia.
The metaplasia. So a metaplasia is an important thing. It is a must thing that should be there in order to get a squamous cell carcinoma. So because of a chronic irritation of the urinary bladder, patient will get a squamous metaplasia. Because of this squamous metaplasia, patient will get this squamous cell carcinoma. Risk factors again same. This chronic cystitis, smoking, chronic nephrolithiasis, okay, cystosomia hematobium. They all can cause the squamous cell carcinoma of the bladder. Patient again will have a painless hematuria. And please note, no voiding symptoms will be present. Very important. Versus in case of prostatic carcinoma, patient again will have a voiding symptoms like, and they will also can have a hematuria, right? So with the painless hematuria, you can either have a prostatic carcinoma, you can also have the all these urinary tract carcinomas. Okay, so look for the voiding symptoms. If the voiding symptoms are present, that means there must be a blockage. It could be a BPH case. It could be this prostate carcinoma. If the voiding symptoms are not present, only a painless hematuria, nothing else, you will always think about all these 4 or 5 cancers we have discussed recently. Okay.
Yes.
And in case of glomerulonephritis, you can again have this hematuria thing. Okay, but in case of glomerulonephritis, you also have the RBC casts, right?
Yes.
So this looking this cast, looking this painless hematuria without any voiding symptoms, it will help you differentiating it with other causes also, right?
Yes.
Okay.
So that's everything on this chapter. Please ask if there's any doubt.
No, thank you.
Let's discuss this pharmacology now. So all the drugs that we're going to study now, they are all listed here. Okay, they all act on a different part of my nephrons. So the drugs which act on the PCT, okay, the first one is the mannitol. Okay, this mannitol can act, because the function of mannitol is to cause the reabsorption of the water, right? Sorry, is to increase the osmolality and cause the excretion of the water, right? Yes.
Yes.
So all the regions of my nephron, which are permeable to the water, that means the PCT and the descending loop of Henle, only in these areas the mannitol can work.
Yes.
Okay, so the function of mannitol is on the PCT and the descending loop of Henle. It increases the osmolality in the nephrons, in the tubules, and as a result, water cannot be reabsorbed and it will be excreted by the kidney. Second is the acetazolamide, which act on the PCT, inhibiting the carbonic anhydrase, and as a result, I cannot have a bicarbonate formation. I cannot have the reabsorption of this bicarbonate and the sodium, so it will be lost in the urine. Third is the loop diuretics, inhibiting the sodium potassium chlorine pump. As a result, I cannot reabsorb the sodium potassium chlorine and they will be lost in the urine. Thiazide diuretics, acting on the distal convoluted tubule, inhibiting the sodium chlorine pumps, and as a result, I cannot reabsorb the sodium and chlorine, so they will again lost in the urine. Potassium sparing diuretics, then you have, which blocks either the sodium channels or the receptors for my aldosterone. As a result, the sodium will be lost in the urine in the collecting duct. Okay.
Yes.
So let's discuss all these drugs one by one. First, you have the mannitol, which is an osmotic diuretic. Okay, it is osmotically active, and that's why whenever it is present, it will draw the water with it. Okay, you give this patient the drug, and it will remain intravascularly only. So what happens is whenever you have a whenever you have a fluid in any of the tissue, okay, extracellular space in the interstitium, if you give the patient this drug, it will draw all the fluid into the intravascular space. Okay, and as a result, you will have a clear of the fluid from this. You will have the removal of this fluid from the tissue space, and it will enter into your intravascular space. Then it will reach the kidneys. In the kidney, because in the tubules you have this drug, and it can neither be absorbed neither can be secreted. So all this mannitol will be present in your tubules. It will draw water with it, and ultimately all this water will be lost in the urine. Okay.
Yes.
So it increases the tubular fluid osmolality and as a result urine flow. It can also be used to decrease the intraocular and the intracranial pressure, because I told you, you give this drug to the patient, it will remain in the intravascular area. It will draw all the water from the tissue, from the brain. So it will help decreasing the intracranial pressure. Same for goes with the eye. Whenever you have an acute increase in the intraocular pressure, acute glaucoma, you can give the patient mannitol to get a relief from the symptoms. But please note, because it is causing the increase in intravascular volume, okay, the volume in your lungs, okay, in your these arteries and the veins in the lungs, it will be increased also there, right?
Yes.
So because of that, patient can get a pulmonary edema as a side effect. Okay.
Yes.
Second thing, because of this diuresis, because of loss of water, patient can have a dehydration. Pre-renal azotemia can occur because of that. Okay.
Yes.
Hypo or hypernatremia. Initially, when you give the patient this drug, because it is drawing all the fluid in the intravascular space, the sodium level will decrease. You will get a dilutional hyponatremia, right?
Yes. Initially.
When the dehydration occurs, you will get the hypernatremia later. So
Yes.
first you will get the hypo, then you will get the hypernatremia. It is contraindicated in the anuria, in the condition where patient cannot micturate. You cannot give the patient this drug. Okay, it will provide it will put an unnecessary effect on your heart, load on your heart, then it can cause a heart failure. You cannot use this drug in the heart failure patient, because if you give this drug in a heart failure patient, it will be increasing the intravascular volume that will put the extra load on the heart, and you won't need that, right?
Yes.
So
Yes.
you cannot use in the heart failure also. So contraindicated in the anuria patient, in the heart failure patient, it can cause hypo or hyper, initially hypo, then hypernatremia, dehydration, and pulmonary edema. These are all the side effects of the patient with the mannitol. You mainly use this drug to decrease the intraocular pressure or the intracranial pressure. Okay. So that's the thing about the mannitol. And
Sorry,
please note, because
may
it
I
is causing the
ask,
yeah.
how can it be a diuretic and increase the intravascular volume at the same time?
Sorry, please ask again. Ask it again, please.
It is contraindicated in heart failure because it's increased the intravascular volume, right?
Yes, yes.
So why it's diuretic? So
Why?
you got the point. Since it's diuretic, so the intravascular volume should be decreased, right?
Because it remains in the intravascular space, right? I told you. It cannot cross on. It can cross this blood vessels, right? It will remain in the blood vessels. So initially, when you give the patient this drug, all of the fluid which is present in your tissue space, it will enter into the blood vessels, right?
Okay.
Then it is the heart which will pump this drug into the in my kidney, right? So
Yes.
ultimately, you will draw all the fluid into the. Someone asked a doubt. Yeah, osmotic stay in the vessels. Yes. So ultimately, what happens? You give the patient this drug, it will draw all the fluid into the blood vessels. It will go to the heart. Heart will pump it. It will go into the kidney. In the kidney, it will remain in the tubules. There, they will draw extra fluid, and it will cause the excretion of the fluid. Right. So initially, you will have an excessive overload.
Okay, it's temporarily.
Yeah, exactly. I told you in the
Okay.
later on you will get a dehydration.
Yeah. Okay. Thank you very much. I might miss that. Thanks.
Now, you can also have the osmotic diuresis in the diabetes also, remember?
Yes.
So both in the mannitol, in the hyperglycemia, you can have an osmotic diuresis. Okay, both in the case you'll be having ultimately the this hypovolemia and increase in the BUN levels, right?
Yes.
Okay.
Yes.
Just give me a second. Yes. So how would you differentiate whether the patient is having a hyperglycemic osmotic diuresis or a mannitol-induced diuresis? They did not give you any kind of a history of the patient. They just give you that the patient is having, this diuresis thing. What other things you must look for?
Frequency.
Differentiating features between my glycemic osmotic diuresis and the mannitol-induced diuresis. Anyone?
The diabetic symptoms, mostly the frequency will be over there.
They will have
Diuretic symptoms will be both in hyperglycemia and the mannitol.
hyperglycemia will have high glucose in their blood.
They did not give you any history of glucose.
The frequency and the urgency will be, I guess.
In both of the conditions, we'll get the frequency and urgency.
Diabetes.
Think about the urine analysis. In the urine analysis, what you will find?
Specific gravity.
Glucose.
Specific gravity will be increased in both mannitol as well as my hyperglycemia.
Yeah. Ketone.
Ketone, well, that only be seen in the diabetic ketoacidosis.
Yes.
Glucosuria
What
will be
about
there.
sodium? What about sodium? Think about sodium. In what disease you will get a low sodium, and what thing you will get a high sodium? Tell me.
In mannitol, there will be high sodium in urine, right?
And what about my glucose?
In glucose, comparatively, it will be more glucose.
I'm asking only about the sodium levels. What will be the sodium levels in hyperglycemia and mannitol?
Hyperglycemia low.
Hyperglycemia low. Why?
Sodium glucose.
Sodium glucose, what? Yeah, you're right. Going right way. Remember the history of patient with diabetes? I told you one thing. What happened before 5 years?
Before 5 years?
The history of a patient with diabetes. I told you natural course of the diabetes, right? Before 5 years, after 5 years, after 25 years. We discussed that previously. What happens before 5 years?
Something papillary. Necrosis.
Now, what's happening in the kidney if I got a diabetes before 5 years of the diabetes? What's happening with my kidney? What
Before
changes you will
5
see in the kidney? Yeah,
Before 5 years, nothing will happen.
nothing will happen, but something is happening, right? Something is happening.
Albumin,
Albumin is not there before 5 years.
yeah, after 5 years, um,
What about GFR and other things?
decreased GFR.
Decreased.
Sorry, initially high
Why high?
because of high pressure, hydrostatic pressure.
See, initially you are having a high glucose load
High
in the
fluid,
filtered.
high fluid.
Osmosis.
High, s-
See, at the very initial, what's happening is I'm having too much of the filter load of glucose in the
Yes.
kidneys, right?
pressure, increased
So,
pressure,
yeah, increased pressure is there, but why? That is a
hydros,
question.
increased fluid, hyperosmotic.
Yeah, hyperosmotic is there now.
Hyperosmotic flow is there, right? That's true.
Um, specific. Question is not specific. Can you make it specific?
I'm asking what happens with the GFR, why the GFR is increasing in a patient with diabetes.
Because a lot of fluid overload.
Okay, that is a one thing, but not a majority. What about my sodium and glucose? What's happening with them? Why low sodium?
Increased
Glucose.
increased sodium in the diabetes.
So are we talking about the transport sodium?
Yeah,
glucose?
exactly. We're talking about the transports. What's happening with them?
Oh, okay.
Overexpression.
Initially, you're having a high glucose in the tubules. Because of this high glucose in the tubules, SGLT2 will get activated and will try to absorb more glucose.
Yes.
In order to absorb more glucose, they need also absorb sodium along with that.
Yes.
So both the sodium and glucose must be absorbed.
Yes.
So if the sodium is absorbed, what's gonna happen to the excretion of my sodium?
Decrease.
Decrease. So that's why you're having a low sodium in the urine in case of hyperglycemia.
Yes.
Okay.
But
Got
a
it.
high sodium in the urine in case of mannitol. And please note, we are not talking about the concentration, we are talking about the amount.
Yes.
Okay, the amount of sodium is low in case of hyperglycemia and the
Yeah.
amount of sodium is high in case of mannitol.
Okay.
Both in case of my hyperglycemia and the mannitol, you will be having a low serum sodium because of dilution.
Okay.
Okay, so please note that fact also. So that's the difference between an osmotic diuresis with the mannitol and with the hyperglycemia. Okay.
Okay. Thank you.
Any doubt on this page, please ask.
No, thank you.
Secondly, you are having the acetazolamide that acts on the PCT, inhibiting the carbonic anhydrase, and as a result, it cannot cause the absorption of CO2 and the bicarbonate. Ultimately, you'll be losing all the bicarbonate and as well as sodium along with that. Potassium also get lost because in the collecting duct and the DCT, all these cells will try to reabsorb the sodium in exchange for the potassium, right?
Yes.
So sodium will be lost, potassium will be lost, bicarbonate will be lost. What you will have is the low level of bicarbonate that will alkalize the urine. Okay, metabolic acidosis will happen. Okay, so this drug could be used for the metabolic alkalosis also. Because it is a diuretic agent, it will be used for the glaucoma also. And again, in order to form this aqueous humor, you also need the carbonic anhydrase there, right?
Yes.
So inhibiting the carbonic anhydrase, I'm inhibiting the formation of my aqueous humor. So this drug can be used for the glaucoma also. For the altitude sickness, because whenever you go high above the altitude, you need the metabolic acidosis.
Yes.
Because you're hyperventilating. So that's why you need the metabolic acidosis for the compensation. Okay, so this could be achieved by giving the patient acetazolamide, and that's why I give this drug to the altitude sickness patient. Okay, it could be used for the idiopathic intracranial hypertension again. Okay, so these are the uses of the acetazolamide. What are the side effects you will get? You will get the proximal renal tubular acidosis. Why? Is it a type 1 or a type 2?
Type 1.
Type 1 is a distal and type 2 is a proximal, okay?
Oh, yes,
type
yes. Thank you.
So it is a type 2 renal tubular acidosis you will get because you're losing all the bicarbonate, okay?
Yes.
You will get the paresthesias, okay? You will get the ammonia toxicity. And I told you, because if you're already having so much of the bicarbonate in the urine, you don't need to buffer the acid right now, right?
Yes.
So kidney won't secrete the bicarbonate, you will be having a bicarbonate, the kidney won't be secreting the ammonia, you'll be having ammonia toxicity. Sulfur, and because these drugs are sulfur drugs, so you will have a sulfur allergy also. Hypokalemia can happen, okay? Hyponatremia can happen, okay? And low level of bicarbonates can also happen. And because it is making your urine alkaline, patient can also have a calcium phosphate stone formation. So these are all these side effects. Please note the location PCT. Any doubt, please ask.
No. Thank you.
Then you have the loop diuretics inhibiting my sodium, potassium, chlorine channels. These are the furosemide, bumetanide, and torsemide. Okay. And so basically they act on the thick ascending limb of loop of Henle. Okay. So what happens is, this ascending limb of Henle, it is responsible for maintaining the osmolarity of the medulla. All the high osmolarity up to 1000 that you see in the medulla, it's all because of this ascending limb. Is that okay?
Yes.
So by inhibiting these channels, you cannot reabsorb the sodium, potassium, chlorine, and as a result, it will abolish the hypertonicity of the medulla. Okay, and because you need the this hypertonicity of the medulla in order to concentrate the urine, because only along the concentration gradient you can have a reabsorption of the water, right?
Yes.
So if you have a high concentration in the medulla, you will have a more reabsorption. If you have a low concentration in the medulla, you will having a low reabsorption. So because these drugs are abolishing the hypertonicity of the medulla, they will cause the decrease in the reabsorption of the water, and as a result, it will help. It will prevent the concentration of the urine. So patient will have a free water loss, and that will raise the serum osmolarity. Is that okay?
Yes.
Now, along with inhibition of these channels, these drugs can also increase the prostaglandins. Okay, and when they increase the prostaglandins, they will cause a dilation in the afferent arterioles that will cause more filtration of this blood, that will cause more GFR, that will cause more diuresis, right? So prostaglandins are also required for their function. If you give the patient NSAIDs, they will inhibit the prostaglandins, and as a result, these loop diuretics cannot achieve their 100% efficacy. They will decrease the effect of diuretics if you give the patient NSAIDs having a loop diuretic, okay?
Yes. Yes.
And they also causes the loss of calcium, because you cannot have the efflux of the potassium now. You cannot have you cannot have a positive potential, and that leads to the loss of calcium as well as magnesium in the kidney. And please note, they are a very powerful diuretics, and that's why whenever you got an acute edema, for example, an acute episode of heart failure, okay, you will always first give the patient loop diuretics. So whenever a patient with the exacerbations of the heart failure come to your department, the first thing you will do is to give the patient loop diuretics, get rid of the edema of the patient, okay? Similarly, for the cirrhosis, in the acute edema, in the nephrotic syndrome, in the pulmonary edema, you will using the loop diuretics first. They're always a first-line therapy for acute edemated edematous states, okay?
Yes.
Side effects, they are ototoxic drug, and especially if you use them with the aminoglycosides, they will cause hearing loss, vertigo, and the tinnitus. Ringing in the ear will be seen. Okay, dizziness will be there. Hearing impairment will be there. Hypokalemia can happen. Hypomagnesemia can happen. Hyponatremia, of course, can happen. Dehydration, sulfur allergies can happen. Alkalosis can happen. Why this alkalosis?
Losing the acids.
What acid you are losing?
H+ secretion.
Because of
Potassium, you're losing potassium.
why potassium is like, I'm not getting. Alkalosis or acidosis can cause the hypokalemia or hyperkalemia. Okay, not the opposite is true.
Lose H+ with potassium. So they have alkalosis.
Sorry, repeat it again, please.
We will have alkalosis, metabolic alkalosis, because of H+ secretion with the potassium.
You're not having an acid secretion, but you're having a reabsorption of the bicarbonate, excessive reabsorption of the bicarbonate. And that's because of a RAS activation. Okay.
Okay.
You're activating the RAS and that's causing it, right? Now, tell me one thing. Although you're giving the patient loop diuretics that will inhibit the reabsorption of sodium, that means the sodium must be lost in the tubules,
Yes.
right?
Yes.
If the sodium is increased in the tubules, then the delivery of the sodium to the DCT will be increased.
Yes.
If the delivery of sodium to the DCT is increased, then why am I having activation of RAS?
Because of low volume, you're losing volume.
That happens very later stage, not in initially.
Because the fluid will follow the sodium. So in the intravascular system, we will have low volume that will activate the region.
The function of macular cells is to sense the sodium delivery in the DCT. It has nothing to do with this my system. Okay, serum doesn't matter. The only thing matter to the macular cells is the delivery of sodium to my DCT. Okay, the sodium is already very much enough. Still, you are having activation of RAS.
Dilation of the afferent arteriole?
For does this dilation of afferent arteriole will do anything with my RAS? See, if you go back to the endocrines part, and if you look in the SGLT2 inhibiting drugs, right? Remember the name of these drugs, SGLT2 inhibitors?
Yeah,
Canagliflozin, dapagliflozins, all the clofazolins, right? I told you that these drugs inhibit the SGLT2, and as a result, they are increasing the sodium delivery and the glucose delivery to DCT, and that's why they're inhibiting the RAS, right? And that's why you will have a fall in GFR whenever you give the patient SGLT2 inhibitors, right?
Yes.
But now I'm saying that because of increase in the delivery to the sodium, to the DCT, I'm having the activation of RAS. The two contradictory, the two opposite statements here.
I don't know.
See, what happens is, along with the blockage of the sodium channels here, okay, these loop diuretics has also effect on the macular cells. Okay, they cause a dysfunction of the macular cells, and as a result, the macular cells cannot sense the delivery of sodium in the DCT. If the macular cells cannot sense the delivery of sodium in the DCT, they think they will be tricked that the sodium is not present at all. And as a result, they will cause the activation of RAS.
Okay. Okay, got it. So it is not sensing. Okay.
Exactly. They're blocking the receptors on the macular cells also.
Okay.
Can you repeat it again, please?
See, along with inhibition of the sodium, potassium, chlorine channels, these loop diuretics also inhibit the receptors on the macular cells that sense the sodium delivery. Okay. And they inhibit these receptors, and the result, they cannot sense the sodium delivery to the DCT. If the cells cannot sense the sodium delivery, they will tricked that this sodium is less. and as a result,
Okay.
will activate the RAS. And that's the result why you're having activation of RAS. If you're having activation of RAS, you'll be having alkalosis, right? Aldosterone
Yes.
effect.
Yes.
So that's the reason you're having alkalosis. Again, because of the dehydration, you can also have a gout. Precipitation of gout can happen. Okay.
Yes.
So, and nephritis, I told you that diuretics can also cause the interstitial nephritis, acute interstitial nephritis. So these are all the side effects of the loop diuretics. Okay.
Yes.
Now, these are all the sulfur drugs. Okay. Then you have a non-sulfur drug, which is the ethacranic acid. Okay. Function is same. Everything is same. It just when the patient is having a sulfur allergy, and in that case, you cannot give the patient these drugs, you give the patient ethacranic acid instead. But please note that it is a more ototoxic drug than these drugs. So for the allergic cases, use the ethacranic acid. Rest all things are same to that of loop diuretics. Okay.
Question.
Yes.
In acute heart failure, acute situation, we give furosemide versus Bumex. What is in terms of potency or the Bumex and furosemide?
Repeat it again, please.
In case of heart failure, acute heart
Yeah.
failure,
Yeah.
you give furosemide versus Bumex.
Yeah.
What is that in terms of why it's because of potency or?
I really don't have any idea about that. Why we give the furosemide instead of bumetanide? It's a step to step, I think, right? All
Yeah,
these
usually,
protocols and other things.
yeah,
I really have no idea why we give that.
I think it's more potent furosemide. I think
Yeah.
that's what.
It could be due to
Yeah,
potency and
actually,
efficacy.
furosemide having a high potency
Yeah,
Yeah.
it could be due to
comparatively
high
to
potency.
bumetanide and torsemide.
Yeah, exactly. It may be.
Potent.
Okay, thank you.
So yeah, and so that would be all about these drugs. Any more doubt, please ask.
No, thank you.
Thank you.
Then you have a thiazides diuretics, and these are the hydrochlorothiazide, clothalidone, and the metazolone and the indapamide. These 4 drugs belongs to the group thiazide diuretics. Function of these drugs is to act on a DCT and inhibit the sodium chlorine channels. And as a result, you will be having a loss of sodium, loss of chlorine. Okay. Okay. So, and please note, they will also cause the increase in the reabsorption of calcium. And because of this increase in the reabsorption of calcium, you will be having a decreased calcium excretion. So these drugs, because they're decreasing the calcium excretion, they can be used to prevent the stones in the kidney. Okay.
Yes.
So one thing is the stone treatment. Second thing, because they're increasing the calcium they're increasing the calcium reabsorption, so they will be increasing the serum calcium levels. They can cause the hypercalcemia also, and they can be used for the treatment of osteoporosis. Okay.
Yes.
Yes.
And they can be used for the treatment of idiopathic hypercalciuria. Okay. And again, because they're diabetic drugs, they will be decreasing the load on the heart, so they will be useful for the treatment of heart failure, for the treatment of hypertension. Please note, the most potent drugs for diuresis are the loop diuretics. They are not the most potent. They can and they can cause a slight diuresis only. So basically, you will use these drugs mainly for the hypertension. So for the edematous state, you will use the loop diuretics. For the hypertensive states, you will use the thiazide diuretics. Okay, and you can also give the loops with the thiazides to give a more effect on the diuresis. Okay, you will generally combine the loops with the thiazides. Is that okay?
Yes.
And why is that so? Because I told you, whenever you're blocking the sodium, chlorine, potassium channels in the ascending loop of Henle, it will cause a more increased delivery of the sodium into DCT. In the DCT, you're having these sodium chlorine channels through which more sodium will be reabsorbed, and that will limit the action of my loop diuretics, right?
Yes.
So even if I block all these channels, the sodium chlorine channels in the DCT also, then this sodium cannot be reabsorbed in my DCT, and as a result, it will be lost in the excretion in my urine, right? And that will be causing a more a more effect. Okay,
Yes.
a potent effect. And does anyone can tell me if this, if I give the patient a combination of loop and thiazide, what kind of an interaction it would be? Synergistic or addition?
Addictive.
I guess synergistic,
Why synergistic?
because the effect will be doubled, not additive.
So repeat again, please. Why
There will be
synergistic?
double effect.
Synergistic,
There
I
will-
think.
Why synergistic? I'm asking.
There will be double
Both
effect.
effect of both is greater than.
How can you say the effect is of both is greater than what I'm expecting? You have not made any calculations yet, right?
Oh, no, actually
As both-
additive. I think additive.
Why additive?
It is the effect of both equal to if they're giving individually.
And how you can say the effect of both is greater than individual? Again, you have not done any maths, you have not done any research. So how can you say? I told you one thing about this additive and synergistic. If both are doing same action and giving you a same effect, then it is additive.
Yes.
If both of them are acting through a different mechanism, causing a same effect, then it is synergistic, right?
Well, it's synergistic. Yes.
So would it be a synergistic or additive? Now tell me.
Synergistic.
Synergistic, because both are having a different mechanism of action.
Always confusing.
Okay.
Yes. Thank you.
Okay,
Thank
do
you.
remember that. So that's about my thiazides. Side effects, again, hyperkalemia can happen, metabolic alkalosis can happen, hyponatremia can happen, hyperglycemia can happen. Remember that this is hypercalcemic drug, okay? Hyperlipidemia can also happen, hyperuricemia because of dehydration, of course, hypercalcemia, and this sulfur allergy can also happen, okay? So these are all the things you will see with the thiazide. Diuretics. And yeah, that would be all about it. Any doubt, please ask.
No, thank
So
you.
if somebody has hyponatremia, you should not give hydrochlorothiazide, right?
Yeah, of course, you cannot give the patient. Then it will stop that, okay?
Yes.
Then you have the potassium sparing diuretics, and those inhibit either the receptors of the aldosterons that are my spironolactone and aplepenon, or they can inhibit the sodium channels, the amiloride and the triamterene, okay? So these drugs would be very useful whenever you give the patient to a hyperaldosteronism because they inhibit the receptors there. Whenever you have a hypokalemia, because when you inhibit the aldosterone receptors, you cannot have the excretion of the potassium, right?
Yes.
So the side effect of these drugs would be hyperkalemia, and that's why whenever a patient is having a hypokalemia, after giving this loop and thiazide, you can give the patient potassium sparing diuretics. You can combine the loop and thiazides with the potassium sparing diuretics to counteract this hypokalemia in that patient. Okay, heart failure again, because they're inhibiting the effect of aldosterone and the RAS, so they will inhibit all these deleterious changes on the heart.
Yes.
Right. So they basically prevent the morbidity in the patient having a heart failure. Okay, so there's a disease modifying drug. Then comes the hepatic ascites. Okay, spironolactone is very useful because I told you whenever you have ascites, you'll be having a activation of RAS, right? Because of intravascular volume depletion. So spironolactone will prevent this condition. Nephrogenic diabetes insipidus. Okay,
Yes.
you can give these drugs, amiloride, for example, very important. Okay, and in the nephrogenic diabetes insipidus, you can also give the patient thiazide diuretics. These two drugs for the nephrogenic diabetes insipidus. Okay, then you have the anti-androgenic effect, because all of these drugs having an anti-androgenic effect, especially this spironolactone. Okay, you will give them these drugs for the anti-androgen actions. Okay, side effects, again, the hyperkalemia that can lead to the arrhythmias. Okay, endocrine effect that can cause the gynecomastia because of the anti-androgenic effect. Okay, so these are all the side effects of the patient with potassium sparing diuretics. Any doubt?
No, thank you.
Then you have the electrolyte changes. We have discussed every one of them already. In the urine, sodium, calcium, all diuretics will increase the excretion of sodium, chlorine. Okay, urine, potassium, loops and thiazides will be losing it. Okay, acetazolamide will be losing it. Potassium sparing diuretics will be reabsorbing it. Okay, blood pH, alkalosis will happen in case of loops and thiazides. Acidosis will happen in case of acetazolamide and the potassium sparing diuretics. Okay,
Yes.
urine calcium, loops will cause the excretion of the urine calcium, so you will be having a more urine calcium in loops. Thiazides will cause the reabsorption of calcium, so low urine calcium in case of thiazides. Okay.
Yes.
Okay.
Then you're having a RAS inhibitors. Okay. And the first one is the angiotensin converting enzyme inhibitor. The function of this enzyme is to convert angiotensin 1 into angiotensin 2. And does anyone remember the location of this enzyme?
Pulmonary
In the lung.
In the pulmonary veins, right?
Yes.
So they inhibit this enzyme there, and as a result, you will be having a low level of angiotensin 2. Okay, so this angiotensin 2 cannot act on the PCT, it cannot cause a vasoconstriction, it cannot act on my this arterial cortex to release the aldosterone, right? It cannot go to the this brain now to cause the release of ADH. So all the functions of my angiotensin 2 will be decreased. So you will be having a loss of GFR. Okay, and I told you also that angiotensin 2 also prevent, sorry, this angiotensin 2 will also cause the this vasoconstriction of the efferent arteriole, remember?
Yes.
So by
Yes.
inhibiting this angiotensin 2, I will be having a dilation of the efferent arteriole. Okay. Now the renin will be increased, angiotensin 1 will be increased. Okay, because of this increase in the negative feedback, because of loss of negative feedback by the angiotensin 2, you will be having an increase in the renin and increase in the angiotensin 1. Now this angiotensin converting enzyme is also required for the degradation of my bradykinin. If I inhibit the angiotensin 2, I will be having a more bradykinin, and that will lead to the angioedema also and the cough also. So cough and angioedema is the side effect of this therapy. Okay, so renin will be increased, angiotensin 1 will be increased, bradykinin will be increased, angiotensin 2 will be decreased, and as a result, aldosterone will be decreased. They all will be used in the hypertension treatment. In the heart failure patient, they will reduce the morbidity and the mortality of the patient. Proteinuria will be useful. I told you they're all very renoprotective drugs. So basically, they will use for the proteinuria, for the diabetic nephropathy. Okay, they will also prevent the unfavorable outcomes of the heart failure. Okay, the heart remodeling will be prevented. Sure. So they are useful for the hypertension treatment. They will reduce the pathological remodeling of the heart. So they will be useful for the heart failure. Okay, proteinuria will be very useful in the proteinuria. They will be useful in the diabetic nephropathy also, a renoprotective drug. Remember that. Okay, so that's all about my angiotensin converting enzyme. So these are the captopril, okay, enalapril, lisinopril, and the ramipril. So all of them has a pril in their name. Okay, any doubt, please ask.
No, thank you.
Then you have the angiotensin 2 receptor blocker. Okay, so up to angiotensin 2, all the levels will be increased. You will have an increased level of renin, increased level of angiotensin 1, increased level of angiotensin 2. But now, because angiotensin 2 cannot act on its receptor, it cannot activate the aldosterone. So you'll be having a low level of aldosterone. Because the angiotensin converting enzyme is normal, you will have a normal level of bradykinin also. Okay, so they block the receptors of the angiotensin 2 AT1 receptors. Effect will be similar to that of ACE inhibitors, but no bradykinin levels. You will be having a high level of angiotensin 1, 2, and renin. low level of aldosterone. Uses hypertension, heart failure, proteinuria, chronic kidney diseases. Okay. And your, of course, the diabetic nephropathy. Okay. All of these drugs are the renoprotective ones. Side effects, they can cause the hyperkalemia. They will cause a loss of GFR, hypotension. Both the drugs are teratogenic. Okay. I told you they will all cause the Porter syndrome, remember? Sorry, the Porter sequence, remember?
Yes.
So they're all teratogenic. And if you're having a renal artery stenosis, in that case, you need the GFR to maintain the renal functions, right?
Yes.
You need the constriction of the efferent arterioles for that. If you give the patient these ACE or ARBs drug, then you cannot have the constriction of the efferent arterioles. And because you're already having a decreased renal perfusion, that will further decrease the filtration fraction of the patient. And that can lead to a rise in the creatinine of the patient. If you're having a unilateral stenosis, you won't have any rise in the creatinine or a very mild rise. In case if you're having a bilateral artery stenosis, in that only you will have a high level of creatinine. Okay.
Yes.
That is important. Again, you will be having a edema. Okay. So a patient after taking a drug having a peripheral edema along with high level of creatinine, think about the ACE ARBs. If a patient is having a normal creatinine for an antihypertensive drug I'm talking about, if the patient is having a history of hypertension, you give him some drug. Not the patient is having a history of edema and a high creatinine, think about the ACE ARB. If the patient is having a just edema without any creatinine rise, think about this CCBs, okay, the calcium channel blockers.
Yes.
Because I told you the calcium channel blockers can cause a peripheral edema because they dilate the arterioles, increasing the blood flow to the periphery. Right?
Yes.
So no rising creatinine, edema, think about the CCBs. Rising creatinine with edema, think about the ACE ARBs. Then you have the aliskiren, okay, and that is a direct renin inhibitor. So if you inhibit the renin, okay, so it will inhibit the conversion of angiotensin 1 to angiotensin 2, and as a result, you will have a low level of angiotensin 1, low level of angiotensin 2, low level of aldosterone. Okay.
Yes.
And what about the renin? Rise or fall? Try. Renin inhibitors, what about the levels of renin, rise or fall?
Rise.
Rise, because they inhibit the receptors of the renin, right?
Mhm.
So negative feedback will be lost and it will have a very high renin production, but it just can do anything, right? So high level of renin, low level of angiotensin 1, low level of angiotensin 2, and low level of aldosterone will be seen in the aliskiren therapy. Again, useful for the treatment of hypertension. Symptoms, hyperkalemia, low GFR, hypotension, angioedema can happen. But it's a very slight type, not a very larger, because whenever you have a conversion of angiotensin 1 to angiotensin 2, then only you can have a degradation of the bradykinin. You're inhibiting this conversion, so you can have a mild angioedema also. Okay, so it is contraindicated in the patients who are already on the ACE inhibitor therapy or the ARB therapy. And these drugs, and all of these drugs are contraindicated in the pregnancy also because they all are teratogenic, right?
Yes.
Yeah.
So that's all about these drugs. Any doubt, please ask.
No, thank you.
So, and one more drug for the hyperkalemia treatment, and that is the patiromere. Okay, and basically what happens is you give this drug, okay, and generally what happens, this drug is combined with the calcium. Okay, so what happens is you give this drug will combine with the calcium, and then it binds to the potassium. Okay, and when it binds to the potassium, it will release the calcium. So initially what happened, you combine this drug with the calcium, you gave it to the patient. Okay, now in the GIT, this drug will lose the calcium, and instead of calcium, it will bind to the potassium. And when it binds to the potassium cannot be reabsorbed in the GIT, and as a result, the potassium will be lost in the GIT, and instead you will have a absorption of the calcium. Okay.
Could you repeat?
This patorimere drug, okay, you will bind it with the calcium and give it to the patient. In the GIT, this drug will lose the calcium, okay, and it will bind to the potassium in the GIT. As a result, it won't let the absorption of the potassium in the GIT. As a result, potassium will be lost in the feces, and instead the calcium will be reabsorbed.
Okay.
Side effects, again, it can cause the hypokalemia, and because of calcium absorption, it can cause the hypercalcemia. It can also cause the hypermagnesemia, and because it is losing all the potassium, water will come with it, and patient will get the diarrhea also, right? Okay.
Yeah.
And now, and please note that this drug always take time to act. So because it is a slow action, okay, so it cannot be used for the acute therapy. It is only used for the chronic therapy. So whenever you encounter a patient having an acute hyperkalemia, you cannot give these drugs. It will take time to act, right? So only for the chronic therapy, not for the acute therapy. Then you have the sodium zirconium silicylate drug, silicate drug, okay, and it is just like the patorimere, but instead of calcium, you have the sodium here. Okay, now this drug will leave the sodium, and instead of sodium, it will bind to the potassium in the GIT, losing the potassium, reabsorbing the sodium. Okay.
Okay.
So sodium zirconium cyclosilicate. Remember this drug, and the patorimere. Okay, these two drugs, they are useful for the hyperkalemia treatment because they will bind to the this potassium in the GIT and causes the loss of potassium in the GIT. Instead, they will have a reabsorption of calcium and sodium. Okay, any doubt on these two drugs?
No, thank you.
So that would be everything on this chapter. Any doubt on the renal section anywhere?
No, thank you.
So we are done with the renal. Okay. From tomorrow, we can start the reproduction. Okay.
Yes.
Okay.
Thank
So
you.
that would be everything for today.
Thank you so much.
And guys, our actually our university is organizing a national conference. So if anyone is interested to take a part, you know, you all can register there, right?
Okay.
Conference?
Yeah, a national conference is organized in this university. So if anyone is
In India?
interested, so they can, yeah, in the India.
Is it virtual?
Yeah.
Is it virtual? Like
yeah, online conference, yes.
Okay.
Virtual.
So
How can we? Oh, we can. How can we register?
It just you have a site which is HISICON 2021. I've shared the link, I think, right, previously.
Oh, okay. Yeah.
So you can go there and you can register. So it will help you in your CV. Okay, that's why I shared that link.
Okay.
For a CV, you need some this certificates type, right? For the conference certificates, all these poster presentations. If you have any kind of research, you can present it there. It will be published there, right? So you will have some these oral presentations or the poster presentations that will be useful in your CV later on, right?
Okay.
So if anyone interested, they can part in it, right? Okay.
So
yes.
Okay.
Yeah.
So,
ask.
Like how to like do is there some entry fee like we have to pay for it? How we can make transaction and
Online
all, like
yeah,
online.
Online it will be. You go on the website, you will find all these things, right? On all these links will be there for the online transaction and for the registration. Registration, I think, up to 25 July. And if you want to submit any abstract, any research, then I think today is the last date for submission. So if you have any kind of a research for submission, you can do it today. Okay.
Okay.
Thank you.
Okay. Thank you so much, everyone.
Thank you for the info. Thank you.
Thank you.